Good morning, everyone, and welcome to the June Oregon Health Policy Board meeting. We'll go ahead and get started in a minute, maybe after I see a couple more board members with their video on, if they're able to.
Hey, Oscar, this is John, just saying hello. I'm sure my video is going to flash, but I'm here.
Thank you, John. Good morning. Thanks for joining us today. I think we have everyone that we were expecting, so we'll go ahead and get started. Good morning, everyone, again. The Zoom chat feature in today's meeting only allows meeting attendees to message the host and co-host and no other meeting participants. Any questions, thoughts, and comments can be sent via Zoom chat to the meeting host or co-host. All materials for today's meeting are available on the Oregon Health Policy Board website and are hyperlinked in today's meeting agenda. We will go ahead and get started with roll call. Tara?
Thank you, Oscar, and good morning, everyone. Oscar Rana.
Present.
Kirsten Isaacson. I know she was going to be on the phone only. I'll check back with her. All right, Brenda Johnson.
Present.
Melina Moran.
Present.
Bill Kramer.
Present.
Sandy Sampson.
Here.
John Santa.
Here.
Great. And Jessica Gomez. All right. We have 6 members present for a quorum.
Thank you so much, Tara, and giving Kirsten just another opportunity in case she just joined us by phone. I know she might be traveling. Well, hopefully she's able to join us at some point later today. All right. Well, first, I want to actually start by thanking Kirsten for stepping in to facilitate the last few board meetings while I've been pulling double duty at my regular day job. So I just want to say appreciate Kirsten's support as the co-chair. I've been officially released of my double duties, so I'm stepping back in to facilitate these meetings. So, oh, there she is. Hello, Kirsten. Nice to see you. I'll give you a minute, but you just missed me thanking you for facilitating the last few board meetings. So thank you so much for all your support while I've been a little preoccupied at work. So,
Of course, apologies for being late.
No problem, no problem. I'm really excited to announce that we are going to resume our out-of-area meetings. These out-of-area meetings are a wonderful opportunity for the board to learn about local community best practices, see work in action, and build important knowledge and relationships. OHPB will resume its out-of-area meetings this summer, starting by hosting our Monday, August 7th meeting in Hood River. Meeting details are still under development and will be communicated through OHPB's website. Please make sure to update your calendars. Also, we are going to convene our annual planning retreat in October in the Bend area. So we'll be coming over to visit Melina and where she's at. Details are still under development and will be communicated shortly. So please start thinking about those, making travel arrangements and holding those dates in your calendar for Hood River in August and Bend in October. Also, the Healthcare Market Oversight Program provided its monthly update in meeting agenda attachment number 1.1. HCMO has opened public comment on the Scan Care Oregon transaction and welcomes comments from OHPB members in their individual capacities. Make sure to to email those comments to hcmo.info@oha.oregon.gov. Please note that comments are posted to HCMO's website, but folks can let us know if they prefer that their comment not be published or if they would like their name omitted from publication. All right, for today, here's what we have in this morning's agenda. We are going to get an update from OHA Interim Director Dave Baden. We'll hear an update from OHA Director Recruitment Process from the Governor's Office and Modus Recruiting. The Public Health Advisory Board Chair and staff will share their updated charter and bylaws. Please note that this is seeking OHPB vote for approval today. We'll hear public comment, and then we'll take a break. Then we'll hear the OHA's Ombuds Program Team will share its 2022 end of year report and highlights and takeaways. Bridge Healthcare Program staff will provide an update in preparation for an OHPB vote of approval on its blueprint regarding at a future meeting we're going to have later this summer. And then we'll get an update from the Cost Growth Target Program on its recent public hearing held in May. And we'll finally adjourn today's meeting. So our first order of business this morning is to vote on the draft May 2023 OHPB meeting minutes. The draft minutes are listed as attachment number 1 in today's meeting agenda and are posted on the OHPB website for public viewing. Is there a motion to approve the draft May 2023 meeting minutes?
This is Brenda, so moved.
Thank you, Brenda. Second?
I second that. This is Melina.
Thank you, Melina. Any discussion? All right, all those in favor say aye.
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 Anybody oppose? Any abstentions? All right, those are considered approved. All right, let's turn it over to OHA's Interim Director, Dave Baden, with an agency update. Dave, I'm sure you've been very busy, so go ahead.
Thanks, Oscar. Greetings, everybody. Dave Baden, he, him pronouns, Interim Director of the Health Authority. Yeah, happy to chat about a few things this morning and leave hopefully some time for questions. I mean, I think definitely top of mind is sort of where we are in now that it is June, this in what would normally be a legislative session would be sort of getting that final budget packages, all those bills would be finally flowing through Ways and Means and getting to final floor votes. And while the budgets are being worked on hard and heavy by Ways and Means, it's really unclear about obviously what's happening around anything else. And the impasse in the Senate is not, I don't know, what analogy you want to use here of not seeing the light at the end of the tunnel or other pieces. Every day, I wouldn't say that the news gets better or stronger of positive outcomes to where things are in session. I know from the governor and her office, is working hard, providing information from executive branch, from on impacts of not having bills pass or not having budgets come out on time. And while on one hand, the legislature's already passed and the governor's already signed a continuing resolution that would operate the state through the middle of September, that is not a good option for the state, with lots of exclamation points at the end of that statement. Having worked in the federal government, living under continuing resolutions is a very normal sort of thing. I will admit that the state's continuing resolution, which had happened before, was always about just assuring that there's enough time for like the budget groups in the state to load budgets in the formal budget system as you get into early July. Like it was sort of literally just like, hey, we need something so that the state can keep going, but the budgets already were passed. We just need a little bit more time to do some technical budget loading. Actually running the state for multiple months on a continuing resolution is not good, and would have some really significant implications on the state writ large. You know, on health programs. I mean, I will, Medicaid, Medicaid payments and money out to CCOs, those things would continue, but just our ability to hire, to operate, to successfully implement the waiver without being able to hire as quickly. It obviously makes the work that is already taxing and stressful much more taxing and stressful. And there are some other real big implications across the state for education funding, for the start of some agencies like the Early Learning Department of Early Learning. So I would just sort of wanted to start with these next few weeks as we get toward the end of session by sort of statute, it's just not a fun, happy place to be. It's not good for the state. It's not for sure good for the health authority to be in this place. There's obviously a lot of bills that are in limbo, some of which that I know OHPB has cared deeply about and put support out there. All those for sure are all completely up in the air, right? What is actually going to happen to any of those policy bills, I think is really unknown at this point. So, happy to jump into any sort of specific related issues on that. I will say that the governor's priority for sure is around getting budgets successfully done as quickly as possible. At a minimum, that is the state's responsibility of the legislature to get a budget passed and get that passed ideally on time with that. So, I did want to say we did get last week our budget, the OHA budget was heard in the Ways and Means subcommittee. So happy to go through a couple of highlights on there. Again, just remember what I'm about to highlight. This is a budget that's gone through subcommittee. It's going to be heard in full committee tomorrow night. From there, it is a Senate bill, so it doesn't go anywhere. So what I am putting out there is what normally would happen through this process, but there's not an end point to what this budget would do. So what I'm saying is not final. It may change. But I just wanted to give at least a sense of where the Ways and Means committee generally are looking on. I would say overall our budget is a good increase over over the governor's budget from our continuing service level. It's about a $2 billion total fund increase and about 400 positions in the sort of the Ways and Means package for OHA. I would say that the biggest highlights of the budget are maybe 3 or 4-fold. First, the legislature is fully funding the work that OHA has asked for to implement the Medicaid waiver. So from caseload implications and other pieces, positions to effectively manage that big bolus of work has been fully funded. Second, the legislature is fully funding the bridge to the basic health plan and telling OHA very clearly that it expects us to work with CMS and successfully work with CMS to implement a basic health plan in Oregon. Again, I think that's great big news that we're continuing down this path to move to a basic health program, and the legislature has fully signaled with its budget that it is on board in doing that. 3 is around the Healthier Oregon program. So the Healthier Oregon program has been fully funded in this budget, just over $560 million to fund the Healthier Oregon program for the biennium. So we are moving fully to be ready to on July 1st to lift the caps that are on the Healthier Oregon program so it can go live for all age groups. Again, big news on sort of the healthcare front. We did get our RealD SOGI implementation data system fully funded. There's a whole variety of other packages. I will say that some of the behavioral health packages were funded, some were not. So, you know, there is a little bit of seeing if that's it, if there's more coming in a later end of session bill. A whole variety of other things. Public health modernization received a $30 million increase. We were hoping for more. The governor's budget had asked for more. So that one, while good, was hoping for more there as well. You know, there are a couple of specific health equity pops, both internal work and some external work that were not included in that package. I'll say I'm working hard to see what I could do to try to work with the legislature on potentially partially funding or funding those programs. We will see in, again, this environment where it's a little unclear of what's going to happen from there. So happy to, I would say we would give a more like standard presentation of this, but I hesitate to do that knowing that I don't know what's going to happen with this. So once eventually we get to a full budget, we're happy to come and go through exactly what 23-25 will look like, but I did want to highlight a couple pieces there. Let's see, I just quickly on redeterminations. I think we we should have some May data here very shortly. Our April data, I think we had talked about before, you know, generally it was in line broadly with what we expected with sort of percentages around renewals, about who was asked to review, sign, and send back their renewal packets. You know, I will say that there are a couple of new dashboards that Tara, maybe you can drop into the chat that get into more detail about what's happening. The dashboards now include demographic information by county, written language, race, ethnicity, gender identity, disability, and housing status of those members. So a lot more granular data now that we're sort of have enough data to really show those sorts of pieces. There will be additional releases over the next couple of months as we sort of get into, by the end of June and then in the coming months, people that have actually received sort of their notice of termination. Again, those will be in the end of June. That would be sort of a September timeframe when they would actually lose their you know, their Medicaid eligibility. There are some people that if they were already seen as over income may already sort of are in that process, but these are people that maybe did not turn back their paperwork and, you know, trying again to give as much time and as much ways to contact folks further. Okay, I'm taking a deep breath. Any questions, Oscar and team? Happy to, you know, talk about anything else on y'all's mind.
Any questions from the board? Oh, John, go ahead.
Yeah, Dave, I know that there's children issues sprinkled throughout this, but my understanding is there was a budget package for children, and I'm confused what the status of that package is.
Yeah, good question, John. So, so there are a variety of budget packages that the legislature was looking at. So there was a climate package, a housing package, John, I think a children's package, a drought package. So there was the legislature was doing a couple of ways. You had core agency budgets, and then these sets of policy combos and budget packages that were going through at the same time. I'm going to give you the message like I've given before. There is zero clarity about what's going to happen to those pieces, John. And I think there is a lot of risk that those from kids package to climate package to other things, like there's a lot of risk that those just die. And I'm not sure what happens to the money that would be associated with that. Again, another part of the big deal of the legislature figuring itself out to pass budgets that includes sort of at least budgetary aspects of these packages, as well as likely there are, I don't have as much familiar about all the things that are in the children's package, John, but there probably are policy or law changes that is, all up in the air about how all that goes.
Can I just ask a follow-up process question?
Sure.
So are Republicans, including Senate Republicans, participating in the Ways and Means process, voting, having input? When I'm trying to imagine what happens when you get to this last day of session and all these folks show up and there's this enormous amount of information and decision making. And are they all going to say, oh yeah, I understand what's here and just vote yes or no? Or, is somebody going to say, wait a minute, this is an overwhelming amount of information and we haven't been around for 3 months or 2 months. So are the Senate Republicans participating in the process other than, going to the Senate floor and saying present?
Well, I will give you an answer on some of that question, John. So yeah, so Ways and Means, there is enough. Both the subcommittees and the full committee, the way that sort of quorum works for those subcommittees, not having a Senate Republican on showing up at those committee hearings still means that there is quorum. So those bills can move. The budget, OHA's budget, for example, has moved out of subcommittee. It will be heard in full committee tomorrow. To go through items and hopefully get voted out from there. So those can continue. The only thing I'll say on bigger picture, I think that there's just a lot of I think you're naming a lot of logistical, timing, and other challenges that the legislature would have to face, period. There's a lot of bills that are on calendars that would have to be dealt with. There's just a lot of logistics that would have to be dealt with that normally are dealt with on a daily basis that now has a lot of pent up pieces that are part of it. So it's again, I think my message of there's not a lot of clarity still remains.
I guess I have a question, probably also difficult for you to answer, but I'll go ahead and ask it anyway. It sounds like on the last day of session, budgets would be approved and potentially a handful of bills. I'm wondering if, agencies are sort of like prioritizing like 1 or 2 bills that they would sort of bring for approval. And if OHA is doing that, what does that process look like? And what would be sort of like top bills that you'd want to be approved?
So we've been working really closely with the governor's office. I think all agencies are doing the same of, relooking at all of whether, agency bills or other bills that have gone in and provided some, feedback of what would be priorities in that list. I'm hesitating to sort of go through exactly what those are, Oscar, to obviously give the governor the ability to advocate what she wants to advocate for in a negotiating position with the legislature. But yes, we are doing that. And if there is no Senate, it's hard to pass anything.
Okay. Other questions from the board?
So I guess just to follow up, so which ones, so there's several House bills, Senate Bill 5525 and House Bill 2446. What would you say are the most critical to get passed for? I mean, the one is, the 1115 waiver and how that's going to be implemented. So what for the basic health program? Are you going to say that's one of your top priorities, Dave?
Yeah, I mean, Sandra, I will say that so both the waiver and getting enough money for implementing the waiver in the budget, I think is the most important. Generally, we did not need additional legislative authority to do what we need to do with CMS for a basic health program. So like big picture, like getting the budget passed is priority 1, 2, and 3. I mean, it's just really important for us and for the state to do that. Sandra, I wish I like the rest of the bills. There are some really important ones, 2 of which you've named. There's a whole bunch of others from sort of agreement on nurse staffing and ratios. Obviously the extension of the CCO contracts. There's just a lot of pieces out there that are super important, and trying to provide some priorities back. And I'm, it's going back right now into a legislature where, again, there's not an active Senate. So for all of us, I think sort of getting to a realization of, I'm not sure what's going to happen to any of those policy bills, period.
Okay.
So I hate painting a bleak picture this morning,
Right.
but I think I've got to.
So then, houselessness and some of her priorities, the governor's priorities, continue to be maintained at a higher level. So are you looking at are you looking at the last biennium as the same dollar amount that was requested, or had that been increased?
So generally, as again, if the state has to start under a continuing resolution, it's based on different quarters of sort of our expenditure, how much we did expend. Again, like we are working hard to make it work if we would have to do that. To get things going. But just a reminder, none of these positions that I talked about potentially coming, those would not be here. It really creates cash issues and a crunch for the state of, how it sort of gets things out. Again, it is not ideal for OHA. I will say for some other agencies, it potentially is even more damaging. Education for sure, higher ed. There's some real big ways that the budget normally works that would not be able to work in a continuing resolution. So, I mean, not a positive way to start if that's what it would happen.
All right. Any other comments or questions from the board? Dave, is there anything, I think I already know the answer to this question, but is there anything that the board could do at this point?
Silence is golden. I wish I had a great, easy answer for you, Oscar.
Yeah,
Yeah,
feel free
I
to-
think, I mean, y'all have thought and put together sort of what are legislative priorities for OHPB. I think revisiting that and then what would be the impact if some of those things would actually not pass seems like a logical thing to sort of relook at a bit.
Okay, well, thank you so much. Thank you so much for all your leadership during this time of uncertainty. So, all right, I think I saw our next presenters already here, so I'll go ahead and introduce them. I believe Abby Tibbs with the Governor's Office, Orlando Williams, and Drayshawn Vance with Modus Recruiting are here today to share progress updates on the OHA Director recruitment process. So I'm going to go ahead and turn it over to Abby.
Hi, thanks for having me. I'm Abby Tibbs. I use she, her, hers pronouns. I'm a senior advisor for Governor Kotek on her executive team. My primary responsibilities, just for context, there are the lead on the state budget. So that's keeping me busy. Working on, I'm sort of the transition person. So a lot of staffing transitions and agency director transitions. And then I'm also partially embedded at OHA, supporting Dave during this interim time to ensure stability and continuity around the governor's key priority areas over at OHA. So it's a pleasure to be here. Maybe it would be helpful have the team introduce ourselves, all of us, and then I will give a brief overview of where things are at with the director recruitment process, and then turn it over to Orlando Williams from Modus to do a little bit of a deeper dive. So why don't we briefly introduce ourselves, if that makes sense? I'll turn it over to you, Orlando. You can go to the next Hollywood Square.
Excellent. Sounds great. Good morning, everyone. Orlando Williams, Chief Executive and Equity Officer for Modus Recruiting. Oscar, great to see you again. And I also lead a portion of our executive search practice and looking forward to working with Policy Board to gain some additional insights. And we'll talk more about that in just a moment. And I'll turn it over to Drayshawn.
All right, good morning, everyone. My name is Drayshawn Vance. I am our Vice President of Executive Search. Nice to meet you all.
And we also have our executive operations, Tasha and Florence here. So Tasha, we'll turn it over to you.
Good morning, everyone. I'm Tasha Wheat Delancey. I use she, her pronouns and focus on operations with Modus.
Awesome. Is that the team? I think so. Okay.
Sorry, Abby. I believe Flo was on.
Oh, cool.
Call.
One more.
Hi, I'm Florence Gerber, Flo, and I'm here as part of the Modus team. And my role is the senior project management to help move the progression of the recruitment.
Awesome. Well, again, thanks for having us. I'll keep this brief. I know we don't have a ton of time. So the purpose of today is to give the high level overview. And then I did have a discussion with the chair and vice chair about setting up the separate opportunity for sort of substantive engagement in the process. But for now, just giving kind of the high level approach. So for the governor, I believe this is the first time in the state, in sort of Oregon's history, sounds grandiose, but in recent history, that we have used an outside recruiting firm that centers an equity-based approach to executive recruitment in the Modus team. And so we have been working through the process, given that like using an outside firm in state government comes with a lot of complications and opportunity, and really trying to understand what is most important to the governor in the search process. And then how are we incorporating community input and feedback into ensuring that we are able to surface and then ultimately hire so that the most qualified candidate into this role. The approach, so the job went live yesterday. We are approaching this as a rolling recruitment so that it'll be open until filled, but the first set of applicants will be reviewed in July. We are using the opportunity on the front end before any applicants are reviewed to do a series of engagements with constituencies of OHA to get feedback about sort of what are their expectations and hopes and dreams of the agency, and then what are the core characteristics, qualities, and attributes that they want to see in a director. That will help inform the rubric and the evaluation of the candidates. Those listening sessions that MODIS will convene will include the Oregon Health Policy Board, the the Governor's Racial Justice Council, the Racial Justice Subcommittee on Health and Human Services, 3 community listening sessions via Zoom. And those will all be happening in the front end of June, so before the applicants are reviewed. In talking to the chair and vice chair of the Oregon Health Policy Board, like really emphasize the commitment from the governor of the role of OHPB in the hiring process, that like getting input from you all on the front end about your expectations and for the director is really important to her. And then we will, as we move through the process, be convening panels that will help us narrow the field of candidates. Those panels will include a tribal panel, an OHA staff and leadership panel, and a community panel as well. On those panels, we haven't sort of sorted out what exactly they will look like. There will be representation from the OHPB. So really, I think leaning into the advisory capacity of you all and the important role that you play for OHA. We anticipate that the goal is to have this position hired within 6 months. We have heard concern about that is too long of a timeline. I think so much of it's just going to depend on what the applicant pool looks like and how recruiting goes. And we're going to have to be sort of iterative and flexible about how we adjust. I'll just be totally candid. Recruiting into state government at this level has been really challenging for a variety of reasons, including just ecosystem awareness around sort of salary and the scrutiny and the complexity of working in state government, especially frankly in an environment like the legislature has set up today. I mean, these are really hard jobs to begin with, and then you layer on all of the chaos and the uncertainty, and it makes it even more challenging. And then OHA in particular has unique opportunities and challenge, certainly like being an agency that's on the forefront of innovation and policy for the nation, and frankly, in some cases for the world, like is really a selling point. And we've had a lot of directors over several years. Certainly the Pat to James to Dave has created media that isn't particularly helpful. So really working with the governor's office and Orlando's team to ensure that like we are actively recruiting in a realistic but hopeful way, so that we are addressing some of those concerns as we go through the process and not leaving candidates on the table who Google OHA or James or Dave or Pat or whomever. And so how do we ensure that we are actively really recruiting in a way that that will ensure that we surface the most qualified, diverse candidates. I think with that, I'll turn it over to Orlando to talk about the approach to the listening sessions, and then to give just an overview of sort of how MODIS approaches the recruitment from their perspective as well. So Orlando, take it from here.
Thank you so much, Abby, and appreciate the level of detail that you shared there. So I'll share that in those listening sessions, it is our goal to create an environment where we can receive authentic feedback. And as Abby mentioned, we conduct inclusive and equitable recruitments, and that has been our approach for several decades now. And one of the ways that we do that is by garnering information from key stakeholders, from community members. We're able to give us insights that will help inform not only the skills and attributes necessary, but also it'll give us insight to make sure that we create a roadmap for success for potential candidates. So in those listening sessions, in this particular instance, and this is still somewhat iterative, we don't want to be too prescriptive on what we ask. We'd like to give the creative license for those who know this work and understand our communities, both urban and rural, that they can give those insights that will help inform the process. But the questions that we will look to ask, there's 4 primary questions. The first is, what do you see as the major challenges for OHA or for health in Oregon in the next 5 years? And we'll make sure we get these to you as well. The second is, what do you see as major opportunities in the same vein? And then we'll ask about a little bit of visioning. So what innovations or vision should be in consideration for OHA or for health in Oregon in the next 5 years? And then our next question is around leadership, is what style and leadership and ways of being and knowing do you want to make sure we have represented in OHA? And then finally, what type of engagement and experience regarding diversity, equity, and inclusion should the next OHA leader possess? So those are the primary categories that we'll start the conversation with, and then we'll move and allow the conversations to take a more organic dialogue, and we'll glean that information, and then we'll synthesize it and give it back, just to make sure that the rubric that Abby shared, that we're aligning that rubric with who we're recruiting in this process. And so that's the listening sessions. And so briefly regarding the recruitment approach, so we trademarked a method called the Better Best recruiting methodology. And what it does is that it emphasizes the candidate experience. So for candidates who are coming from underrepresented communities or have been historically marginalized in processes like these, we want to make sure that they can, 1, bring their authentic self, 2, that they can bring the best version of themselves, and secondly, that we can make sure that there are spaces that they can convey their experiences, their talents, and their gifts in a way that they can be appreciated. And there's methods to that work. And then also we make sure that those who are panelists, which is in critical importance, are participating in an inclusive process. We don't make the presumption that individuals who have interviewed for decades even have the skills to recognize where bias shows up in interview processes. So we have a training session for all of those panelists that Abby mentioned, and we take them through our Better Best recruiting bias training so that we all are able to calibrate and walk through together so that we synthesize information following those interviews, and we can do it objectively, identifying, as Abby mentioned, the top individual for the role. We call them the best and most aligned. We don't use language like fit. We look for alignment for the mission and the role itself. So that's a little bit of a high level introduction to our process. But I think the takeaway is that it's an inclusive and equitable process where we make sure that there is a diverse candidate pool represented, and that those who have voice and need to bring voice to the process do so in a way that they feel appreciated and heard. So Abby, I'll turn it back over to you.
Yeah, I think, Oscar, we're happy to entertain questions, or I think that was it from our end.
Great. Thank you so much, Abby and Orlando, for that update on the director search. Just, really happy to hear that we're sort of kind of making history here by doing this a little bit differently than we've ever done it before. So really appreciate the governor's desire to do something unique and innovative and to include lots of stakeholder input. Curious to hear if fellow board members have any questions or comments. Brenda.
Thanks so much for the presentation. This is really exciting and very useful. I wonder if you can give a little bit more about the scheduling of the listening sessions and how you intend to recruit participation.
Yeah, thank you for that. The scheduling for the listening session for the OHPB, I'm going to defer in large part to Oscar and team about. I understand maybe we are going to potentially use one of the education slots, but I think that one I'll sort of put in a parking lot for a minute. For the 3 community listening sessions, we are going to rely heavily on the existing OHA team to invite the constituencies from that their teams work with. So we have developed a preliminary list of folks that we will, in organizations that we will ensure get the invite, but really relying on the community teams in particular to share that. We also appreciate that there will be folks for which a listening session in that environment is not conducive to their willingness or interest in sharing. And so folks will also in that invite have an opportunity to contact Orlando's team directly to have a private conversation. So really trying to facilitate that, and then also taking into consideration multilingual opportunities and how are we going to factor in those considerations, both for the listening session and then also for folks that want to reach out individually, and how do we ensure that there's proper services available for that. So certainly open to feedback if there are things that we haven't considered that come to mind for you all, but that was the general approach.
Yeah, and Brenda, I can let you know that we're still going to be working on the date for the webinar, or we're currently working on that, and we'll try to, scheduling is pretty challenging, but we'll try to get that figured out in the next week or two, and try to have it somewhere in the next 4 to 6 weeks.
I just have a quick question. So just on the tribal side, we usually do SB 770 in July. And that would be a good opportunity to meet with all 9 tribes and NARA, because we do have 9 tribes here in the state of Oregon. And I did hear you, Abby, state that that was an inclusive panel. So that would be a good opportunity to get that completed.
Thank you for that.
Other questions for the Modus team or Abby? John?
Yeah, I think about 6 months, and this is really important. And I know timing is important, but it's so important to get this right, if you ask me. And, the tumult referred to is going to go along at whatever its pace is. And, my 2 cents would be however long it takes to get it right and do it right is the way to go. And it sounds to me like you're headed in that kind of direction.
Thank you, John. And I'll jump in and just say that the rolling recruitment affords us an opportunity to create a very wide net for recruitment. And because we're using a combination methodology of both direct sourcing, the advertisements, and in this market, John, most of our talent comes from direct sourcing. Candidly speaking, it doesn't come from advertisements.
Right.
So we will be very intentional about how we go to market, but you're absolutely right. We want to get this right. We want to make sure that we're finding talent that represents the mission and the vision of the future for OHA. So your words are well taken from our team's perspective.
The only other comment I'd make is I've certainly lived through some very chaotic situations in private companies that where things are just as bad or worse, but they don't have outsiders who are, can throw grenades into the process. And my hope is that folks will let you all do your work and be patient and be supportive. So good luck.
Thank you for that.
I guess I just close by saying that, from the governor's office perspective, we're super excited about this recruitment. We think of all of the places where the state thrives. It is in huge part in the work that OHA does and the transformational change and policy that has come with your leadership and out of this team. And so I think even with the challenges of the ecosystem overall, we do really deeply believe that this should be an attractive job, and that we should be able to source some really amazing candidates, given the work that has transpired previously, and frankly, where the agency is today, with significant progressive public policy being implemented over the next several years. So, I would just want to leave with that sense of hopefulness, and totally agree, the timing of getting it right is really important as well.
Great. Well, thank you so much for coming to our meeting today and giving us an update on this. The organization that I work for, NEA, actually has used Modus in the past, and we were really happy with our process and our search. So thank you so much for all your work. We're really excited about working with you in this very key leadership role for the agency. And we look forward to staying connected and hearing about like the next steps. So thank you so much.
Awesome. Thanks for the opportunity.
Thank you, everyone. Thank you, Oscar.
So Oscar, I just have a quick little question before. So the first round, it says that the people that apply by June 30th would be like the first go. So with that said, if you're getting feedback from any other organization, that really doesn't give you a lot of opportunity to meet with individuals. So I guess, I mean, it is, it's June 6th and that closes. And so how does that actually occur for feedback from the diverse group that you want to, have those listening sessions?
Sure. Thank you for the question. So we intend to have the listening sessions all completed by June 30th. And certainly if we cannot achieve that, I think we will revisit that when we review the applications. It still may be that we sort of hold that date and review the applications through them, but that we wait until those listening sessions happen. I mean, we are deeply committed to ensuring the listening sessions inform the evaluation process. So if there is a hiccup in scheduling, then we will address that as we go. I will also say that the Modus team and the DAS team in the governor's office will be sort of working alongside, I think, to build out the rubric for evaluation as the listening sessions will happen, so that it'll be like an iterative, so that we're not, so that we're doing the work concurrently. So that we will be ready for review of the applications, but our full intent, and unless there's some extenuating circumstance that's beyond our control, would be to have the listening sessions for sure, and to ensure that those are reflected in the approach to review of the applications. And certainly appreciate that the timing is of the essence. We anticipate getting the listening sessions invites out really shortly, and to give folks like a few weeks notice at least in order to be able to attend those, so that we're not like creating a fire drill for folks to be able to adjust their schedules to attend.
Okay, thank you. It was just a question.
Yeah, no, it's a great question. Thank you.
All right. Any other final questions? All right. Well, thanks so much.
Thank you. See ya.
All right, we're going to move on to our next agenda item, which is actually going to require a vote from the board. So Veronica Irving, Public Health Advisory Board Chair, and Kara Biddlecombe, OHA's Public Health Division Deputy Director and FAB Lead, are here today to share FAB's updated charter and bylaws for discussion and also a vote of approval. Thank you for joining us, Veronica and Kara. So go ahead and take it away.
Great, thank you. So good morning. Again, my name is Veronica Irvin. I'm the chair of the Public Health Advisory Board. Kara Biddlecombe is here with us today. Kara, please feel free to add as we go along. And for all the committee members, please feel free to ask questions throughout for me. We're here to present an update of what FAB has been doing this last year in terms of updating our charter and some work on our bylaws. So just for a quick recap about FAB, the Public Health Advisory Board, it's a 17-member group, one of the committees under the Oregon Health Policy Board. And we have a broad committee membership across the public health systems, local public health departments, a university, federally recognized tribe members, somebody from the CCO, public health experts, somebody with experts in methods and evaluation. So we have a broad range, and again, a broad range across the state of who's represented as well. So after I shouldn't say after the pandemic, but it's still technically going on. We still have COVID, but during the pandemic, we realized some changes that the public health system wanted to make. And so we began first in 2021 and 2022 with a health equity review. So we did this through a series of retreats that we held with our FAB members across several months of reviewing our health equity procedures, actually doing some reflection of our own members. And then from there in 2022, we spent about 6 months working on our charter, actually going through and making some updates, removing some items that we had already completed. In your packet, you'll see, and I believe now in chat, the charter without track changes. It may be longer than some of the other committees have more objectives, but it's fairly, we didn't really lengthen it. We just sort of updated some of the terminology and some of the partnerships. So first, some of the recommendations broadly is we definitely make sure to center it on health equity throughout. We also added definitions about governmental public health systems, the public health systems, as well as community-based organizations. Throughout the pandemic, we had a lot of support, both from the locally recognized tribes and community-based organizations. So we have added more intention in our charter to name them throughout some of our objectives and activities. I don't know if it's helpful to actually share the charter on the screen, or if you would just like to ask me questions. I can go over some broad changes, but don't know if it's helpful to have someone screen share just for a moment.
I think we all have it, and I think we've
Great.
reviewed it. So,
Yeah. Okay.
just given the length of the charter, it might be tough to do a screen share on it, but
Sure.
yeah, we all have it.
Great. So basically, in a nutshell, that was our expansion as the partnerships, making it more explicit in the charter, removing items that had already been completed, and then again, focusing on health equity throughout. Any questions for us on our charter?
Yeah, well, thank you so much for all your work and for bringing these important documents to us for review and approval. Curious if folks have any questions on the charter. Brenda.
Thank you. This is an incredible body of work, and it's exhaustive, in terms of its reach, its depth. So thank you, and thanks to FAB for its deliberation on it. My questions are based on thinking about these terms across the very complex system that is OHA. My curiosity starts with the definitions that you mentioned, Veronica. Is this specific language replicated in other parts of OHA? And therefore across other parts of OHPB's committees. So we'll start there.
Great, thank you for that clarification. Kara, do you want to add about the community-based organization definition?
So thank you for the question, Brenda. This is Kara Biddlecombe, she and hers with the Public Health Division at OHA. So in developing the charter, and truthfully, in the progression of the public health system's pursuit of OHA's 2030 goal to eliminate health inequities, I think just by way of how we've gotten here is that there's been some language confusion around, kind of the scope of FAB and the actual work of public health to be broader and more inclusive of community-based organizations and community members and leaders. So that was where the differentiation between governmental public health and public health system broadly needed to sort of be in place for the charter to really help identify what specific activities apply to the public health system broadly versus governmental public health, because there are certain statutory functions there. Community-based organizations, I could see that as something that likely has a potential impact across other parts of the Health Policy Board and its committees. And so perhaps that's something that we could take back to the Health Equity Committee. And if we need to do some alignment or adjustment, we could do that in our next update to the charter. Again, this was sort of to tease apart some of the differences between governmental functions and non-governmental functions, but also recognizing that our public health system relies on both.
Thank you, Kara.
Other questions or comments?
Oh, no, I just, Umatilla tribe was probably one of the fourth tribe of 575 tribes to be public health accredited through the governmental system. So we understand the process, and I appreciate all the hard work that's gone into this. And and recognizing tribal consultation through government to government relationships. But it is a tough, it's a long road to get accredited, whether it's through the government or through the state. So I do appreciate all your work, your updates. So I'd like to make a motion if there's no other discussion on both the charter and bylaws.
Is there a second?
Second.
All right, discussion. There's a couple of points. Oh, John, did you raised your hand? That was to second the motion, or did you have a comment?
Oh, I have a comment.
Okay, go for it.
Yeah. Well, I like others, I think I'm impressed with the effort here in the document, but also concerned. I always try and look for, well, to what degree are the people that we're serving involved? How will they be represented? How is the patient, the public? But this is a public health. This is a population. When I look at the membership, it looks like some of those folks could be, closer to, for lack of a better word, what I would call real people, who aren't experts in public health, but are experts in communities and all. As I looked at it, I wondered, given the experiences we've now had, how will this group sort out what's happening at the schools, or happening among employers, or happening in the unions with workers? Because I think all of us remember how difficult it was to bring those issues together, but we've learned a lot. So I just put that out. The other thing
could I address that, John?
Sure.
Great.
Sure.
So thank you very much for that question. It actually is a great segue into our next discussion, which is we actually do want to expand our bylaws, the members that are on the committee. I think Kara can explain the procedure a little bit, but we would expand it to include 2 community-based organization representatives, one from a rural area, one from an urban area. We'd also have an expert in health equity, as well as a representative from the early childhood system. So we do want to bring somebody from the schools involved in early childcare onto the system. I'll let Kara maybe talk about where it's at in the process, and then John will go back to your next question. Kara, would you? Yeah, thank you.
Yeah, thank you. So thank you, John, for teeing us up, and Veronica for starting to answer. That's sort of as Veronica shared. First was the FAB's own work as a board on our own equity capacity building, and then came our update to the charter and then the bylaws. And in looking at our charter and bylaws and how we wanted to increase the scope, or not we, I'm sorry, but how the board wanted to increase the scope, really needed to look at representation on the board itself. And so sort of given where we were at with developing the charter and bylaws, and then our legislative timeline, an amendment to Senate Bill 965, which is now passed both chambers, did include those 4 positions that Veronica mentioned. So those 4 new positions, 2 community-based organization representatives, 1 urban, 1 rural, an expert in health equity, and then a K through 12 or P through 12 education representative would all come onto the board after January of 2024, when that part of the bill is effective. So we will have to make another update to our bylaws to reflect that membership, but this was as far as we were able to get pending. This bill just passed about 2 weeks ago. So,
and I just asked Kara to post it in chat for us. Just again, the members, it was unanimously approved by our board, and again, had just been passed this last week through legislation. So we'll just see us again for a quick update in a few months, but we are on that track. And so, John, I hope we answered your question, and I'd love to answer the next question.
No, that's terrific. Then the only other comment I made was during this last month, Director Baden sent out, I think, a kind of a newsletter to all employees of OHA. And for me, at least, it was the first time that kind of in a document, he mentioned how successful Oregon was at dealing with disparities during the epidemic. That I think in terms of vaccination rates and other kinds of issues, the processes that you all use, and I think you all played a leadership role in this, were very successful. In fact, my recollection is we were the most successful state in the US at dealing with the disparities issues. And, my hope is this group would keep that up, share that knowledge. I'm very interested in how really did that happen. I know it was because of the equity efforts, the community-based organizations, et cetera. There should just be more information about how that happened. So congratulations on that.
Well, thank you for noting that. And it was definitely attributed to the many people who work in the public health system at OHA, at our local health departments, and at CBOs across the state that really partnered together and did a great reach. So we're hoping to continue that partnerships and hopefully when a pandemic is over and we can continue this as we serve the public health. Thank you for that. Brenda, do you have a question for us?
Yeah, I've got two for you. Just recognizing the first one is lack of information about the track changes. So perhaps you can give a kind of a high level summary of the most major significant shifts from the last approved version to this one. And then I'll ask my second question after that.
Yes, great. So so we added in the definitions. So first of all, so there's a change in the very front page. The commitment to health equity was in there previously, but just wanted to make sure we highlighted that. Towards the end of the first page, we really focus on the partnerships between LPHAs, tribes, CBOs. So throughout, whenever we discuss those partnerships across those entities, that was added intentionally. The definitions have all been added to those sections. If we look under the deliverables, on the left-hand side, everything that's the duties for statute were not changed. Everything on the right-hand side, the FAB objectives, that's where we made some edits. You'll see we made in Part A some intentional direction to actually partnering more with Oregon Health Policy Board. So we would really like to have more. I know we are still waiting for an official member, and I'm not here to plead for that. I know everybody is spread thin, but we want to make sure that we come and talked with you. We had a presentation a couple months ago from OHA about the relationship between the policy board. So really making sure we have more discussions with what are your priorities and how we fulfill that. We also focus on adding in health equity. And then throughout, again, sections that say C and G is where, again, we really strengthen the verbiage around tribal health, CBOs, OHA, LPHA partnerships. We also changed some wording, in sections D and E. Originally, public health modernization was being set up in the original charter with determining the foundational components and capacities. And at this point, that's been set. So we're now in the monitoring, evaluation, and updating it. And let me see about the last parts. The last sections from, let's say, H through J is, again, updating anywhere around CBOs, tribal health programs. We've focused also on CLO, which is the Coalition of Local Health Officials, to make sure that they were also named in our charter. And then we did mention health equity in our section C, I believe, as well on the last page. So again, focusing on that. I think those are my big take-home points. Does that seem, Kara, if I missed any?
Veronica, you covered it very well.
Okay, great. Thank you.
Thanks for that for both of you. And my next question is, with a charter and a body of work that is as broad as this really is required to be, I'm curious about, I'm imagining the deliberations in the conversations you had as a group and as a board about how you find focus in the midst of a span of control or a span of overview and connection points that is as diverse and as broad as yours. So maybe we don't have time for that today, Oscar, but I think I'd be intrigued at, recognizing the breadth of this, where are you actually targeting very specific initiatives this year, next year that you think are important for OHPB to pay attention to and to track?
I could give just some brief overview of generally. So we do have a lot of our work is done in subcommittees. So we have 4 subcommittees, 3 subcommittees plus the evaluation one. That's not a formal one. So we definitely have 3 formal subcommittees that does a lot of our work that's in statute. So they meet regularly throughout the year. And then we also have time to set up about updates about our big items, public health modernization, evaluation around the state health assessment and the state health improvement plan. But in terms of some of the other broader picture pieces, we do leave time at the end of each meeting for our members to voice what would be the next other upcoming agenda items. And then we have an in-person retreat in July to focus on our work for the next year. That's not what's required in statute. So aside from what we have that we're already working on in subcommittees, what is the pieces we want to focus on? I have not seen the final agenda, but I'm guessing that the big broader pieces will be how to continue the partnerships around the government, the public health systems, governmental public health, CBOs, tribes, and workforce development and sustainability.
Any other comments or questions from the board?
Sorry, I have one.
Go ahead. Go ahead, Christine.
Just that I appreciate that OHA staff has been kind of filling a void of OHPB not being able to have a liaison to this like critical committee that is obviously moving an enormous amount of work. And so I appreciate OHA staff doing that in the interim, and I look forward to actually having a board member fill that critical liaison position soon. So
thank you.
for your patience.
And I know that there's a few of you and so many more boards and committees than there are individuals on your board. So perhaps we can come back in fall at some point with an update formally to the bylaws with the new membership and an update about what was our strategic planning this summer for our next items. And then we can make sure that we come back and present to you to make sure that there's still a dialogue between our 2 committees until we have a permanent.
Yes, we definitely love additional updates from FAB at future board meetings, particularly right now, since we've been operating without a liaison to this committee for a while, and we know it's a priority and we are trying to make that happen. So I appreciate your patience and your flexibility during this transition period that we've had since Dr. Bainsberg left the board. So I do have a couple of just really I'm going to vote in a second. I'm going to vote in support of it. So, but I just have a couple of really, minor thoughts and suggestions for future consideration. And these are just like tiny word things, but we all know that words do matter. So I just kind of wanted to put this on your radar for future opportunities. I think on the charter, on the second bullet point on page 1, it talks about, OHPB's health equity definition. And I really want us to think about that as not just being OHPB's like health equity definition. It's now, I really want it to be seen as like OHA's health equity definition, right? Like it's like something that the entire agency has now like is moving towards, and it's not just contained within the board. And then the other minor one is towards the end, right under duties, sort of that last section of duties and FAB objectives. You talk about some of the health equity sort of focus and health equity work, and you do sort of mention at one of the 4 bullet points that you collaborate in health equity efforts. But I'd really like this section to sort of like kind of speak to the close partnership within the health equity committee, right? I really want to make sure that, maybe it probably exists and it's probably already happening, but I think you just want to really like sort of emphasize that there is that strong connection and support between the 2 committees.
Thank you. And I believe that because I know that the Health Equity Committee is also making some updates. So once we may make some changes again, once that's finalized, and that they were at a previous subcommittee meeting discussing our iterations of the Health Equity Review Policy. So we are trying to make sure that we have shared discussion.
Yeah, thank you. Oscar, if I could just briefly comment on that one. We're updating, but FAB is updating its health equity review policy and procedure, and we had some members from that working group attend the Health Equity Committee meeting last month, and we have a process both for having members kind of join that working group to update the policy and procedure, as well as provide some written updates for folks that can't make an additional meeting on top of their other duties. So we're really looking forward to that partnership and feel very supported by the Health Equity Committee for sure.
Great, great. And then, I would also just echo some of the comments we've already heard from John about the membership. I totally agree. I'm really excited to hear that you guys are already working on that and are figuring out a way to address it. And then I would also echo comments from Brenda about just like how exhaustive the charter is and how many objectives and duties are within this one committee. So really, well, one, kudos to you all for all your great work. And two, as you go into your retreat, like really thinking about, are there other ways to sort of potentially, be more strategic about your priorities, or how do you prioritize? My whole motto is that less is more. So figuring out about like what are the things that you really want to accomplish in the next couple of years or so. All right, any other comments or questions from the board? So let's see, just to reiterate, we have a motion from Sandy to approve the charter and the bylaws, and a second from John. We've had a good amount of discussion. Let's go ahead and call the vote. All those in favor of adopting the FAB charter and bylaws, please say aye. Aye.
Aye.
Anybody opposed? And anybody abstain? All right, this has been unanimously approved. Thank you so much for all your work. Yeah, congratulations.
Thank you for having us today.
Of course. All right, let's move on. We are now going to move into public comment. I believe we have one person who wants to provide, at least one person who wants to provide public comment today. So we'll go ahead and get that ready. So let's see. The Oregon Health Policy Board welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, and listen with the thoughtful attention, respect, and honor that you deserve. Public comments are meant to provide everyone with an opportunity to share their perspective and be heard. However, public comments are not a representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share, and if that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help keep us on time, we'll start a slide with a 2-minute timer for each presenter. We kindly ask that presenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the board chairs and staff to determine the appropriate next steps. Board staff will communicate the next steps with each public speaker. And I believe we have Kevin Fitz, who's going to provide public testimony. Kevin, go ahead when you're ready.
Very good. For the record, my name is Kevin Fitz. My pronouns are he, him, and his. I'm the executive director of the Oregon Mental Health Consumers Association. Public comment, June 6, 2023, Oregon Health Policy Board. We request a thorough review of the grant award process for request for grant proposals S4400, especially as it relates to the evaluation and selection of providers for peer respite services. I'm not going to read that whole number, but I'll send that in to you. It has come to our attention that subjective interpretations during the applicant evaluation process may have led to the selection of providers who lacked the proven experience and capabilities to successfully stand up and deliver high-quality peer respite services. In order to ensure that the grant funds are awarded to the most qualified providers who can effectively deliver on the stated objectives, we respectfully request the following be implemented: a transparent public report detailing the applicant evaluation process, an audit of the evaluation and selection of all awarded providers, a review of all rejected applicants to identify any providers with stronger qualifications, remedial actions as needed, including potential reevaluation of applicants and selection of alternative providers. Finally, policy changes to ensure more rigorous merit-based evaluation criteria and processes are implemented for all future grant award processes. Transparent, fair, and objective grant processes are essential to ensure taxpayer funds are awarded to providers most capable of delivering on program objectives and goals. Basically, the state of Oregon offered peer respite RFP processes and selected 3 contractors. I want OHA to say they believe and have total faith in these 3 contractors. And if they won't say that publicly, I want them to follow our letters of concerns and review that grant process. We have a lot of questions about that process. Thank you very much. And I have sent in a written piece to accommodate my comments. Thank you.
Thank you so much, Kevin. We will follow up with you. All right, we are going to take a short break and we will be back in about 10 minutes. Maybe we'll have a little bit longer since we're doing good on time. So let's go ahead and come back at 10:05. So we'll resume the meeting at 10:05. All right, we will go ahead and get started. If I can just see board members do either a thumbs up or turn their video back on, so I know that folks are back. Hi, Bill. All right, Brenda. All right, awesome. Okay, we are going to keep moving forward with our agenda. We have Sarah Dobra and Alan Pinney with the OHA Ombuds program join us today to share about the Ombuds 2022 end of year report. They'll help us understand and apply its findings and recommended next steps. We appreciate your hard work on the report. Please go ahead and begin when you're ready.
Hello, members of the Health Policy Board. My name is Ellen Pinney. I go by she, her pronouns. I am the principal ombuds person for our program, and I'm with my manager, Sarah Dobra, who will introduce herself when she starts doing her slides. I got the first few slides. I don't know if you all share screens here. There we go. Thank you so much. We keep finding in other languages the definition of ombuds, and I love this definition in Amharic, which is a language spoken in Ethiopia. Ombuds means keeper of the people's tears. Next slide, please. Oregon Health Authority ombuds are legislatively mandated to serve as advocates for people who receive Oregon Health Plan and Medicaid services. We're required to report quarterly to the governor and the Health Policy Board. We do that through your subcommittee, the Medicaid Advisory Committee. Last time we presented to this board was in September 2021. We hope to present our annual findings to you on a regular basis. Our findings at the year end go over also recommendations, key areas that we have concerns about and recommendations. Next slide, please. Sarah.
Thank you, everyone. I'm Sarah Dobra. I use she, her, aya pronouns, and am here representing the OHA Ombuds program, presenting with Ellen. And I did just want to say, as we go through our presentation today and share some of the key findings from our 2022 year-end report, feel free to ask questions along the way, and Ellen and I will monitor chat for each other as we're presenting. We may let you know that we'll get to your question later on the presentation and maybe not answer at that point, but we love interactive presentations. So as we dig into this together, feel free to put questions in chat or raise your hand, and we'll try to take those questions as they come and also save time at the end. Is that okay with you, chairs, as well? I want to make sure that makes sense.
Yes, thank you.
Perfect. Well, there's a few grounding principles we like to share, and we've shared many of these before with you as a board, but I think it's important when we think about who comes to the Ombuds program and what their stories tell us, and how we understand that as an agency and how that ties into our agency commitment to eliminate health inequities and to do that in co-creation with community. There's some important things to understand about the Ombuds program. And first is that we truly understand and operate on the understanding that one voice from one member can give the voice to many others. Many individuals who come to our programs explicitly say that they understand that what they experience is also experienced by others, and they come to the Ombuds program because they want us as an agency to understand and want an advocacy perspective to think about how we can design our services to best meet the needs, to best deliver Medicaid to those we serve. And so we truly understand and value each individual we speak to, the stories they entrust us with, the support we are able to provide by walking alongside Oregon Health Plan members as they experience multiple challenges accessing healthcare through Medicaid. We feel that trust and value deeply and act on that as sharing those experiences with the Oregon Health Authority, particularly our Medicaid partners, so that we as an agency can listen, learn, and act on these individual concerns. also really essential and tying into our enabling legislation is that beginning with our 2021 year report, our Health Systems Division, who administers Medicaid, began treating our ombudsman's report as public audits with a response and action plan. And that was done with the leadership of our Medicaid director, Dana Hiddle, to really understand that these reports should move from reports to action, changing and influencing those we serve. We can go on to the next slide. This is just where you can find publicly facing on our website. If you Google Oregon Health Authority Ombudsman Program, our reports are there at the very bottom. And we also have information about our Ombudsman program in the languages seen. So just sort of giving you a snapshot too of what it might look like in some of entry points to our program. And next slide. Our report itself has a lot more data, and we're always happy to answer questions about that, but we just wanted to give you a high level snapshot. We had 2,221 total concerns that came to us in 2021. That's a small percentage of all Oregon Health Plan and Medicaid members in the state. And so that's where we understand that the stories and narrative give voice to so much more. Of that, 1,732 of those concerns were Medicaid concerns, with the largest percentage of those, almost 40% related to access to care. And that's everything from eligibility questions changing from one CCO to another, finding a primary care provider, NAMT not picking someone up, to some of the topics we dive into this report. And really important, I just wanted to call this out as the board does think about waiver and future work. We did find for our non-Medicaid concerns, 1 in 4 of those non-Medicaid concerns did come from Oregon Health Plan members with socially determinants of health needs. And these include concerns about housing, food, and other Oregon Department of Human Services benefits and other social concerns. So just thinking about that interconnectivity, even in the concerns that we didn't classify as directly Medicaid related. We'll go on to the next slide. So today we want to do a little bit more in-depth dive into 3 of the key recommendations in our 2022 annual report. And those are thinking about access to Oregon Health Authority administered home and community-based services, specifically a subset called 1915I. Also thinking about mental health and substance use disorder residential capacity, and emergency department and hospital discharge planning, and understanding and recognizing that these member experiences and walking alongside members are what shape the recommendations and experiences that we share with you. And so we'll get to the next slide. This is a little bit deeper data dive. For the following recommendations in these 3 topics, we did a much more in-depth review of the 263 concerns that came into our Ombudsman program last year that were mental health related to hospital concerns, residential rehabilitation, emergency room, and alcohol, drug, and substance use disorder concerns. And we learned from these members who came to us, or advocates acting on their behalf, both providers and family members, what these stories and experiences were as we walked alongside members. And so just want to give you that deeper detail of when we say, like, what does one concern mean and what do we learn from it? These are the individuals that we were privileged to share experiences with, hear stories from, and bring to you the recommendations that we do. And so with that, we'll go to the next slide and I'll turn over to Ellen. Oh, and actually, I think I'll do one more slide. Next slide. So as we dive into these 3 key recommendations and go through some of the intricacies of Medicaid that we experience with Oregon Health Plan members as they advocate for them, this visual helps me to think about what we too often experience, what Oregon Health Plan members experience, and we in the Ombudsman program have experienced alongside Oregon Health Plan members. As individuals seek to experience access behavioral health services, particularly the areas we call out, this funnel helps me to think about what we see and experience. Many individuals have needs. Individuals who might, as they seek to enter the services, very few get through. And we think about who gets through in the image above, or who needs these services in the image above, and who gets through. Individuals who have disabilities, additional physical challenges, health challenges, maybe they have family members that also need care and support, maybe have gender identities that impact which residential care they go into. These individuals are so much less likely to get through this narrow funnel already and access services. So as we dive into Ellen talking us through our residential, our home and community-based services, I think this image helps me to understand what that looks like for those we serve. And we also experience that closed doors throughout rather than welcoming doors.
Next slide, please. So I'm just going to share a story. These are on the slide, what you see are what we call composite stories. So they might be stories that reflect several different members' experiences. I'm going to share one story that kind of reflects the first two bubbles there. Sarah and I both got these videos from somebody I would call an angel, a street angel, who was outside a hospital and saw a man curled up in a fetal position at a bus stop, writhing in pain, saw the security guards leave him there, was in scrubs. He had fecal material on his scrubs. The security guard said, "Wrong place, there's nothing we can do for him here." Saw him later at a different hospital ER, also discharged. At this point, the street advocate realized and understood that the man also had schizophrenia, drove him herself to a third hospital where he was admitted. He was discovered to have a spinal infection. They did surgery on that on his spine. I think as a result of the surgery, but also as a result of how long the infection might have been here, there in him, he wound up disabled and in a wheelchair. And in part because of the fact that he had a physical disability as opposed to a behavioral health disability, the hospital and the CCO and the Oregon Health Authority, in this case it was Aging and People with Disabilities because they serve people with physical disabilities, were able to find him a home who serves people with physical disabilities. I talked to the home provider after our client was discharged to the home, and he said the client was really happy. He could get around, he could do what he liked to do, which is smoke a lot of cigarettes, and he couldn't run away from the home because he was in a wheelchair. I think that is a kind of, unfortunately, a story in part about the fact and the gross inequities our program sees between people whose disabilities are driven by physical or potentially developmental issues compared to people whose disabilities are served by, are driven by behavioral health issues. And I think we've heard both from the Oregon Public Guardian, who's part of the Long-Term Care Ombuds program, and from a private guardian who serves many of our clients and brings them to us as she seeks care for them, that in the community, there's a lot of work going on to try to squeeze people into physical health disability classification and definition, because then there is much more likelihood that they're going to be able to get access specifically to the residential supports they need. Any questions about what I just said? All right, next slide, please.
I have a quick question, Ellen.
Yes, please.
Just working with your program prior. So at one time, working with aging people with disabilities, we're able to, I guess, relate it. So we got a navigator position that was funded, and that kind of put the community kind of engaged with a tribal member versus not. There's a lot of personal questions in regards to becoming this, being a dual eligible individual for OHA. So I guess even that and discussing the three concerns that that you have is also that smooth handoff and the emergency room, I guess, making sure that there's a referral or someplace to put individuals, and that seems to be a big problem throughout Oregon, and even, you know, for tribal populations, Eastern Oregon. How is that handoff, a smooth handoff done? But that access to care, the quality of care, and then channeling that member for other recommendations for services seems to be there's something, that has to be done in regards to that. But a lot of times people don't know about your program. I mean, if you look at the numbers that you had presented, there's a lot of people that don't understand where to get to you to actually discuss some of this information. So I know it when I met with your department, about 6 years ago, it was, in the same thing as trying to get access to care, access to services. You were a great link. So I do appreciate what you do, just by actually reading some of the base services that individuals need. So I appreciate that. Thank you.
I just want to say there was a lot in that, in what you just shared. I appreciate that you shared it. When I hear dual eligibles, I think of people who have both Medicare and Medicaid. And for those folks who are some of our most vulnerable, we have, that would be a separate kind of sharing of that challenge. But some people refer to dual eligibles also as people who have more than one kind of disability, like now this client of ours has. And I would just share that our colleagues in HSD Client Services Unit receive hundreds of calls every day from clients, a very different kind of public service. Clients come to us as a last resort, not a first resort. If they came to us as a first resort, we really couldn't do our job. I think the numbers, the clients we have in our program right now have multi-layered needs. And one of them, Sandra, that I think we're gonna talk about a little bit at the end is actually the need for care coordination. So thank you for that. Can we go to the next slide, please? So basically, it's important in the context of understanding our report to understand this big overarching theme, which is that people with disabilities have a right to home to be evaluated for, and if they are found eligible, served through home and community-based services. In Oregon, this is about maximizing independence, the ability to stay outside of a residential setting, because that should be, when you are in a residential setting being supported by others, it's kind of the last step. Really, you want folks to be served in their homes by folks who come in to help them with activities of daily living. In physical health and developmental disability world, you go knock on APD's door, Aging and People with Disabilities, that's part of DHS. You knock on the door of DD services provided to folks with developmental disabilities. For folks with behavioral health, this passageway is not nearly as clear or as understood or as supported for our clients with disabilities. So next slide, please. Currently, the way it works, if I have a disability and I knock on APD's doors, Aging and People with Disabilities, I'm going to be screened for whether or not I qualify for residential or in-home supports. And if APD believes that maybe Likely, my disability is driven by behavioral health. They engage a contractor who evaluates me. The point being in part to see whether or not I am a APD client or a client who needs behavioral health services. If they decide my disability might be primarily driven by behavioral health, they send me again to the community mental health program, which may or may not be picking my case up to evaluate me again for the need for in-home and community-based services based on my behavioral health condition. Again, these are home and community-based services that should be provided to all people equitably. We believe this is a process of screening people out. It operates in silos, it increases service gaps, and what our own cases have shown is that this results in a 4 to 6 month delay for people in need of services who, if they're coming out of the state hospital, for example, or out of a hospital in general, they need those services now, or else they're going to go back onto the street and potentially re-enter corrections again, especially for those with behavioral health as a driver. Next slide, please. So for our program, what we would like to see is that there's a no wrong door. When I knock on that door, regardless of my disability, somebody is evaluating me once for the services I need. Do I qualify for residential supports? Do I qualify for in-home supports that would allow me, that would maximize my ability to live independently in my own home? Next slide, please. And this is Sarah's.
Thanks, Ellen. And I'm going to go into the next area we called out in our report, which is members experiencing and seeking residential services, particularly substance use disorder services. And I want to make one important distinction. What Ellen just shared and thinking about residential and home and community services is something that is not capitated to our coordinated care organizations. Coordinated care organizations are required to and should provide care coordination for their members needing those home and community services, but that is administered by the Oregon Health Authority. This next section, particularly substance use disorder treatment, both inpatient and outpatient treatment, residential and outpatient treatment, is fully capitated to our coordinated care organization. So I want to make that distinguish as we make recommendations. The previous ones were very much directed towards the Oregon Health Authority and our administration. These recommendations and these experiences are directed both towards coordinated care organizations and how the Oregon Health Authority administers and ensures that what we intend in contract for members is carried out for this service. So I want to distinguish those two, but let's start and center ourselves in those we serve. And again, these are composite stories, but represent the experiences of so many others. And again, like the stories above, these stories were often brought by advocates, by individuals whose family members acting, working in conjunction with the individual seeking services and had those social supports. So we know so many individuals don't have that. And those are the individuals we particularly concerned about because they don't reach our program. But I'm just going to read these stories because these composite stories and these voices do speak for themselves. I called my coordinated care organization asking for residential substance use disorder providers. They gave me a list. I called them all. None had space available. I didn't know that a coordinated care organization care coordinator was what a care coordinator was, or that they could help me. When I finally found a facility, that facility was not contracted with my coordinated care organization. My family paid out of pocket for my treatment. I found a substance use disorder treatment facility with availability, but they were unable to care for my medical needs at the same time. I couldn't complete substance use disorder treatment. I need a residential treatment, but the provider says there is a 6-week wait for Oregon Health Plan clients, or I can pay $26,000 out of pocket and begin treatment tomorrow. We can go to the next slide. And we think about this and this shared responsibility of both coordinated care organizations and the Oregon Health Authority. These numbers were a snapshot in time last year. They could have changed slightly, but we looked at the total number of substance use disorder residential facilities available in Oregon to meet our state's population. There's 47 facilities, at least at that point in time when we looked. We looked then and again at that point in time, and 36 of those were residential facilities who were contracted with Oregon health plan providers. And then we found that the average number of residential facilities that individual coordinated care organizations contract with is 9. This is a very imperfect analysis. It doesn't tell us the number of beds available per 1,000 members by CCO or by region of the state, but it does give, if we go back to the funnel example, this narrowing example of what we see anecdotally in our OMSIS program stories is Oregon health plan members in different regions of the state and with different CCOs all face barriers to accessing care, but some face disproportionately additional barriers based on that reduced network, reduced regional availability, or lack of care coordination and support to really advocate and get someone into care. So that limited bed availability statewide and then even for members. We also found that, and this was, you know, in that composite story, individuals who have co-occurring substance use disorder and mental health treatment face barriers. There's fewer facilities, and then there's also payment and administrative barriers both on the CCO and OHA side that there's work to do and make more streamlined for the individual navigating treatment and the providers as we have worked those cases. Those intent and work streams toward that have not led to the desired change for members up to this point. We also find incredible responsiveness by our coordinated care organizations to think about creative solutions when there is a facility and a bed available for a member with a facility that member is not, or that CCO is not contracted with. But I will defer here to those of you, I know some of you have far more expertise and working knowledge of substance use disorder treatment than I, but I think what I have learned from many of you is when someone seeks substance use disorder treatment, the moment in time to get that treatment is the moment they ask for care, that individual asks for care. It's not after there has been a back and forth process between a provider with a bed available and a coordinated care organization to do an administrative paperwork process that could take anywhere from a day, if expedited, to several weeks, depending on that process and member-centered focus, to create a single case agreement between a CCO and a residential facility provider to allow that individual to open here. So again, calling out there is responsiveness, and yet this narrow funnel of provider networks does mean members have this experience. And then additionally, for individuals who need to have medication-assisted withdrawal management prior to entering a residential facility, that's one more Tetris piece of this funnel that often leads to individuals simply not being able to get care because that is a further narrowing. We'll go on to the next slide. We have more recommendations in our report, but really, I think calling out, this is a very different model than what OHA's current approach is. But we recognize we do not have enough facilities statewide to meet the need of people in Oregon around substance use disorder. And thinking about that all CCOs should contract with all willing licensed substance use disorder facilities in the state rather than that narrow number and funnel that we saw. Ensure that OHP members have timely access to appropriate substance use disorder treatment and ensuring that there's care coordination to support that. Expand statewide service capacity for all residential providers, particularly substance use disorder providers, and for certified mental health home care agencies. And then ensuring that we have clear expectations and standards for coordinating access to care for those services that are carved out of the contract. So those goes to this co-occurring mental health and CCO treatment. And then for the benefits administered by the Oregon Department of Human Services and for fee-for-service and CCO members. We sometimes see when there is lack of transparency from payer source or what the payment amount will be, providers in an already limited network are disincentivized to think about serving our OHP members. And so ensuring that that's a vital piece of the puzzle as well. We'll go on to the next slide. And I will turn this over to Ellen for our final sort of recommendation, and we'll have some discussion time too.
I'm going to try to run through this really quickly, but Sandra Sampson, I think this gets to partly of what you were referencing. We pulled data for 2022 that showed that in 2022, 11,000 patients came to the emergency department in substance use crisis, and only 1,478 were admitted. That's 13%. We found that 9,191 folks entered the ED in psychiatric crisis, and only 1,100 were admitted. At the point you are admitted to hospital, the obligations of the hospital and the care coordination that can result have a much higher bar. What we have observed is that sometimes hospitals don't want to admit patients in psychiatric crisis because I'm sure you've seen the reports. It's very hard to find for them to find placement. At the point someone's in their hospital, they might be in there a long time before there is able to be an appropriate residential treatment facility or other programs identified for the client. ED visits are a missed opportunity to connect unhoused members, members in psychiatric crisis, and members in substance use disorder crisis with the services that their CCOs do provide. Primarily, go to the next slide, please. Care coordination. So we would like to see much more close collaboration between emergency departments with clients present who they know are part of a CCO or fee-for-service program with care coordinators. We want to make sure that members who have a guardian, actually the hospital contacts the guardian. I just worked with a member's case last week where this did not happen. Her son was discharged out of the hospital, even though he was in psychiatric crisis. She had not been notified. This piece is so important. Another case we worked really demonstrated that, and the CCO got hands into it and said, okay, the police will not pick up this client, even though the client is out in the highway with a hoe, flagging down cars and asking for cell phones and smashing them. This client is not considered by the police to be a danger to herself or others. Therefore, the time we're going to catch her is when she gets into the ED. And at the point she gets into the ED, please hold her so we can arrange for secure transport to a facility where she can be evaluated and assessed. This client, by the way, is thriving now, but it took over a year to get that agreement navigated. It is, this care coordination piece is so essential. Next slide, please. This is our last slide, and then we're happy to take questions at any time, actually. We prefer folks to come into our general ombuds office email. You can always CC myself or Sarah. It allows us to track cases, assign cases appropriately, call on each other for expertise as needed. You can also call this toll-free number. And I believe that is the last slide.
Thank you, Sarah. Thank you, Ellen. Oscar's internet just went out, so I'm going to step in here and welcome questions or comments from board members. I'm operating on one screen, so if you raise your hand and I don't see you, just pipe in. Sorry. Brenda, go ahead.
Thank you. Gosh, this is so important, you know, and I'm thinking a lot about and reflecting with you about the way that we use individual situations to look at systemic issues and try to think about some of the work of the policy board really tackling those systems, you know, using this information and these lived experiences as a way to inform shifts in the way that we organize ourselves and the way we do work together. This is kind of a loaded question, so I apologize, but if you were to think about some of the heaviest lifting system work that you would love this board to focus on, what would it be? I mean, that's unfair, and maybe take it offline and come back and share that with our board. But it's like these cases at the personal level, they're so powerful. Yeah.
They are, Brenda. And I have to say that it was hard for our program, actually, and then I'm going to ask Sarah to reflect as well. It is a perfect question. I really appreciate the question. It took us a long time to get to these 3 priorities, and for which we have recommendations for each of them. I think and there are many other pieces we could focus on, but these 3 were the ones we thought were the most important. There's some pretty low-hanging fruit there for the Health Policy Board, including the ones Sarah mentioned. Like, why does the Oregon Health Authority not require all CCOs to contract with all substance use disorder facilities to maximize the chance that any client in any CCO has equal access to immediate substance use disorder treatment? That's a pretty low-hanging fruit piece, in my opinion. It would be a question that the board could ask. Another one for me is the one door, right? So if I'm a person with a disability, regardless of my disability, I should be able to walk into one door, be evaluated once for my services, and be connected with those services. Our agencies, OHA and DHS, split that process. It is not healthy for our clients. And it is why we hear from the public guardian and from private guardians, we do everything we can to squeeze our clients into these other classifications, because then we know they can get access timely. And in your system, it just doesn't work that well. I would say, I believe that is in part because APD, not that long ago, some are here that know, I'm looking at Bill Kramer, probably others among you, we were one agency, and one agency did it all. And then we separated, and our agency, the Oregon Health Authority, is still learning to pick up these pieces that aging and people with disabilities knows how to do. That's been their history. We have a lot to learn from them. So I would just say that. Sarah, did you want to add anything there?
I don't think I could, say what would be the one area, but I think just 2 call outs. I think feedback we received after we did release this report, and I think right feedback is we have an absence in this report of calling out the incredible barriers and even further limited resources that are thought about and invested in children's mental health at all areas and stages of that. And so we, as a program, quite frankly, just did not have the capacity to tackle these weighty subjects we brought in the report, and the incredibly weighty subjects of children's mental health, and even thinking about unequal access and funding streams there. So I just want to call that out as I think feedback we received on that report that I think is rightly given of we in the OMSIS program modeled what it occurs across our systems of prioritizing a heavily needed area by ignoring the group where interventions and focus could also really limit some of what we're trying to upstream think about. So just calling that out as a gap. And the other just difficulty, or 2 other areas I think potentially for Oregon Health Policy Board thinking about is we did include financial information on looking at the percentage spent on substance use disorder and mental health as compared to all other capitated services on CCOs. And looking at that as a board and understanding amount spent per member on substance use disorder services by CCO and by our fee-for-service program, we can know statewide need and we can make informed decisions about what's going on if we also understand where the money that we have put into the system is going. We have the data and tools to do that. And so I think that's a very concrete area. And then one final just sort of area I think of need, or I think what we experience is a disconnect in the OMSIS program. We know members experience is Oscar so well called out, saying the Oregon Health Policy Board health equity definition is OHA's health equity definition. And I, in my time in this agency, have seen us as an agency embrace that and struggle with what that means. How do we implement that in our Medicaid policies to actually think about priority populations that have faced historic and contemporary injustices? And we're saying and thinking about that, but operating in a system with rules and processes that are clearly designed to ensure inequitable access. Aging and people with physical disabilities, you go here for a service. If you have a mental health need and are over age 21 and have 2 or more activities of daily living that you need support with, go to this door. And if you don't qualify here, go over that door. And so we're using words and have new values, but the tool sets we have to implement them are based in inequitable and often racist rules. And that's a disconnect that's so hard to interrupt in what we experience daily.
Great. Thank you, Sarah. John, I see your hand up.
Yeah. Well, I found this to be pretty disturbing reading. You know, I try not to look at screens before I sleep. Unfortunately, I read this before I tried to go to sleep. It was disturbing. It's just disturbing. Not unpredictable. Not, you know, this is what is happening in a system that's based on competition. You know, when you compete, one of your best strategies for succeeding is to get rid of the folks who are the most difficult. And that's what we're trying to figure out, you know, how to sort out. A couple of things. In a couple of places in the report, I found it very concerning from an access point of view that a substantial number of substance abuse units, primary care doctors, specialists weren't participating. You know, we've focused a lot on workforce, and I don't think it's low-hanging fruit, Ellen, but I mean, it's time to ask, why are there people practicing in Oregon who aren't serving the Medicaid population? Well, some of them aren't serving the Medicaid population because they don't make them enough money. You know, realize as a primary care person, I think we have a medical group, if you will, in the state that has multiple sites. And their practice is owned by Amazon, by the largest company, one of the largest companies in the country. And their specific strategy is to not serve Medicaid. They have 0 Medicaid patients. And I get emails from them at least once a month that are marketing emails. They want people like me. They don't want Medicaid folks. And at some point, it seems we need to ask ourselves as a state, is that right?
Right.
So I think some of the substance abuse units that aren't contracted don't want Medicaid folks. I think some of them do, and for one reason or another, the CCO has a concern of some sort about that. But I think we should try to sort that out and see what we can do in terms of the state requiring insurers, whether they're CCOs or otherwise, to have a relationship with everyone in a category when there clearly is an access problem. If there's no access problem, then you don't need to do that. So that one is a good issue, I think, to think about taking up at OHPB. It'd be a good retreat issue, I think, and be within our boundaries. The other issue that stirred me up was the fellow, curled up on the park bench, who has been to 2 hospitals and not taken care of. And thanks to a street advocate, it sounds like, a 3rd hospital was convinced to treat him correctly. Let me get on my soapbox a little bit. I want to make sure everyone listening knows that there's been a performance metric in existence for many years that's been incentivized that tries to reverse the known discrimination that mental health folks have when they go to an emergency room with a physical health problem. This fellow is a perfect example of that. And while there's been some improvement in that metric, there's still a long ways to go. I've lost track of whether it's either on or off our incentive list. I know there were folks who argued it should come off. And now some of those folks argued it should come off because it's really not about equity. And Ellen, I think you used the term equity a couple of times. It is about equity, and it is about discrimination. And mental health folks are actively discriminated against in the delivery system. I think equity is in our territory, and we should go back and get involved in that aspect. So I think there's a lot here. I'm not sure that today and in this venue, I know quite what to do, but I'd urge that OHPB talk more further in a serious way with OHA and others about what role we can play and how we can play a constructive role.
Can I say how much I appreciate Dr. Santa? I've known John Santa for many, many years, since before I came to the state, how much I appreciate your passion and care. I'm sorry it kept you awake. I know that to be the kind of person you are. John, so thank you. I want to say that the information Sarah pointed out that's in our report, which looks at the total capitation rate CCOs are paid versus the amount of money they pay on behavioral health, is one window into why we are not increasing capacity. I think the disparity in pay between providers who are willing to accept OHP versus what they can get on the private market is another area. I know for a fact, because we get these cases, we have providers who are pounding to get in the door of a CCO, and CCOs don't necessarily want to contract with mom and pop kind of small behavioral health practices. They want the big box shops. I think that needs to be reevaluated, and we put that in a previous report, actually. I thank you.
Yeah, Ellen, your comments, there was some content in the report that you all looked at data about what % of costs are going towards mental health by CCO.
Yeah.
And it was just disturbing.
Yes.
I mean, we know that there's variation, but how can one CCO be at 3% and another be at 17? The only way that can happen likely is through selection. That one CCO in a variety of ways has been able to select patient populations that hardly have any mental health problems. And another CCO is getting all those patients. I mean, that's one concern I'd have. Of course, another is one CCO has set up all these obstacles and barriers that the others don't have. But that data was also really disturbing. Really disturbing. If it's anywhere close to being correct, that's pretty disturbing.
Sarah, did you want to add anything there?
Just one additional comment, and this calls out we have a small OMSPEDS team. We have 5 OMSPEDS staff, Ellen and myself. And John, you're speaking to how disturbing this kept you awake. We have a team who cares. As we share these stories with members, we're incredibly conscientious that it is not our experience. It is not us, the individual as OMSPEDS, who is having the bad day. We are walking alongside someone who we as a society oftentimes have neglected and ignored. And yeah, I just want to call out how proud I am, how thankful I am for the small, dedicated team of OMSPEDS that we have, who are incredible advocates and do this hard work day in and day out alongside members. And then with our coordinated care organizations, in partnership and collaboration, we have these so many CCOs conversations where we dig into this and think about on an individual level and on the systems level, what can be done to improve, and internal to our agency at the Oregon Health Authority. And so it does become exhausting when you, as an OMSPEDS, advocate with members and then have these collaborative conversations where you need to speak truth in a system that's still designed in an inequitable system while we say something else, both externally and internally as the agency. And so I want to call out that exhaustion and yet grateful advocacy for the OMSPEDS team in this work as well.
Yes, thank you, Sarah and team. Oscar, I see your hand.
Yes, and my internet kind of cut out, so I apologize for that. I'm sorry I didn't get to listen to the last couple of slides and also my colleagues' comments. I caught John's comment, which I sort of had a similar feeling, in the sense that, you know, it was a difficult report to read, honestly, just because of you know, some of those experiences and stories that you capture. And at the same time, like, I found myself pretty, you know, sort of like having a lot of emotions. I was very like riveted by by what I was reading, very captivated by it, very frustrated by it, you know, also feeling like, oh my gosh, like some of these challenges are so big, right? Like, what can we do? What, you know, and then at the same time, some of them being so minor, where I'm like, this should not be an issue, right? Like the mileage reimbursement rate, or the, you know, sort of like the transportation challenges for folks. I'm like, these are logistical things that should be addressed immediately. So I guess, you know, part of my thoughts and comments, it's like I just kind of wanted these sort of reports to be like shared, like with the legislature. You know, I was like, more than even just us, like I found myself wanting to be like, this data, this data needs to be like measured, it needs to be communicated, it needs to be sort of like, obviously all the things that we're already doing, but I just kind of felt like, what else could we do to sort of continue to sort of pay attention to these things and monitor its progress?
I want to say I really love that Dr. Santa suggested it's the subject of a board retreat. I know Sarah would be happy to be there. I think, I'm sorry, Melinda, I jumped right in there, but I just want to say, I think it's deeper than you have time for now. And I think there are some pretty not so hard to lift solutions, actually.
And you know, I just want to say, when Pat Allen came, it was just Ellen, right, Ellen?
Correct.
And I think Pat and OHA leadership have taken this on. You know, I read that now your reports are similar or have the status of audit, and the audit methodology and the requirement that there be a response. You know, by no means has OHA ignored this issue. In fact, they've done some terrific things. That's why we're able to have this discussion. because there's always been awful things in our health system. It's just the degree to which it comes into the light of day in a credible way. I think it would just be interesting to discuss the next step here in terms of solutions and constructive solutions.
Great, indeed. I'm gonna call on Melina to share comments, questions, and I have some questions and comments, and then I'll turn it back to you, Oscar, to take us to our next agenda item.
Yeah, thank you. I just want to say thank you so much for your work. This is so important. I am actually a provider in a substance use disorder clinic, and so I deal with this daily. I have OHP patients, this happened just last week, who walked in and needed residential, but unfortunately, we were told they have to wait and fail outpatient treatment before they could go to residential. And so that means sending them back out to the street where they could return to use, risk overdose, risk death. And that is a frequent occurrence. So thank you for bringing these stories to the forefront for everyone to hear, because they're not heard, right? We don't talk about them. And I also want to thank you for using non-stigmatizing language in your report, because as we know, people with substance use disorder have a lot of shame, stigmatization against them, and I appreciate that. And I definitely second that we definitely talk about this and see what we could do as a board to resolve some of these issues. Access is a real thing. So thank you.
Great. Well, I feel like we have like pretty good, or I think many of us on the board are agreeing that let's continue to talk about this. How do we both like make sure these are priorities on our work plans moving forward, so that we can maybe encourage some of these solutions faster? And also, I think how are we creating a platform, kind of, Oscar, like you said, whether raising it to the legislature or others, so that like this great report and some of the upsetting observations are not buried, that they are sunshined and therefore addressed. So I think we should take this into our report and perhaps, or into our retreat, I meant to say, and perhaps into going in depth in an educational webinar. Actually might be another opportunity for us to really delve into particularly where mental health money funds are going within our capitated systems and contracts, and what actions we can suggest from there. And I also want to make sure that we address pathways and there being no wrong door. And I think, we have kind of penciled in behavioral health as a priority work area for the board. And so I think this report can help provide great guidance on where the board could focus our efforts, or I would like to use it that way. I have Trilby, I see your hand up. I have one total like minor question. Oscar, you brought up the like mileage reimbursement rate, and non-emergency medical transport has been such a like ongoing issue in all of your reports. It's sad to see it still there in some ways, but the solution, which was great, it is a total step forward to say, hey, CMS, you need a higher rate. But I was simultaneously like, wait, why is it 75% of the IRS rate? Like, I get reimbursed for mileage from my employer. Why do I deserve the full rate? And an OHP patient going to a doctor's visit should only get 75. And so I was wondering if that was like, anyway, that's crazy, but is that like what other states do, and that's the best we can ask for? Or why 75?
I don't know. And Tara, maybe we can make sure we follow up with our Medicaid policy team who is actually driving that. That's I think a this great partnership, where OMSA's program can speak and directly advocate and articulate where changes are needed. We don't get to implement those. I will just say, since we're touching on NEMT and touching on the tireless advocacy of our program, particularly last summer, when gas prices were, I think I heard on NPR yesterday, like $1.50 higher than they were today. We were hearing from OHP members who could not get to their medical appointments because of that. We raised that internally, and we're told, and this is a capacity issue, it's a prioritization issue, it's this disconnect I've touched on. We are told that's too much work to request for CMS, for us as an agency to request CMS to do. We're not going to do it. That took continued and ongoing Ombudsman's advocacy and work, and a committed internal team within our Medicaid policy team who is moving that change forward. But I just wanted to give that as a touching example of this exhaustion in advocacy that does occur in this disconnect. Even when we're in the midst of that, and $5.50 for gas prices, and in that moment in time when it's so visible, the answer is too much work, we're not going to do. And so it's just a perfect one. So sorry to get sidetracked, and I feel like, Kara, we can always help you support, figure out how to get that answer from our Medicaid partners.
It is a great improvement. I don't want to belittle that giant step forward that getting even 75% will be. It is a great improvement. But anyway, Trilby.
You're on mute, Trilby.
Thank you, Ellen. I just wanted to start out by adding my voice to all the expressions of appreciation for the work that the Ombuds program does. In my prior life, I did legal services advocacy, and, I really understand the battle, especially to raise up these individual stories and have them taken seriously at a policy level. And really appreciate that OHA has taken steps toward doing just that, and that all of you are developing such compelling reports and bringing forward such compelling stories that people have had the courage to share with you. So thank you. And I'm hearing loud and clear from the board that this is a good subject for the retreat. I wanted to flag one other point of connection, and that is I know that Oscar and Kirsten have a meeting coming up with Ebony Clark. And to hear, she is our new behavioral health director, previously had a seat here on the board, very passionate. And I think it'll be important to hear more about her connection to this report and these recommendations. And I see Sarah and Ellen nodding, and I don't know if we have time today for you to tell us about how that's been connected, but I'm sure those connections are happening. And that's one more really important opportunity for us to explore what the board might want to dig into. So thank you again, and looking forward to more discussion.
Just real quick, I want to say thank you for that. Great respect for Ebony. So glad that she's here. Big lift. She's been involved with some of these 1915I conversations. It's complex stuff. I also want to say you have a great behavioral health committee, and we work closely with Maria Williams and her team. Brilliant ideas there. And I think they're tasked with developing metrics and potentially could work on some metrics related to this piece. So I want to say, I hope they also come. That was just my little piece. And we are really grateful for Maria and her team.
All right. Do you want me to take over, Kirsten? All right. Thank you so much for your help, Kirsten. Appreciate that. Any other comments or questions for Ellen and Sarah? All right. Well, thank you again, Ellen and Sarah, for the great report. We appreciate all you do, and we will stay connected, especially as we move forward with our retreat planning. All right. Next item, Tim Sweeney and Laurel Swerdlow, policy analyst with OHA's Health Policy Division, join us to share updates on the basic health program. Basic healthcare program. Thanks for coming back. Please go ahead and take it away.
Great. Good morning, y'all. Thanks again for having me. I'm Tim Sweeney. I'm the policy lead for the OHA team working on the basic health program. And as Oscar mentioned, I'm joined by Laurel Swerdlow, who's our project lead, who will also be here to help answer some questions that y'all may have. So I'm excited to be back with some updates on our ongoing policy and program development work and to provide some information to y'all on how the creation of the BHP is expected to affect consumers purchasing coverage on the state's health insurance marketplace. I think we have some slides and the agenda I think is on the next screen. I'm going to offer a few updates on work underway since we last spoke before turning attention to the bulk of the presentation around how we're working to mitigate the impact of the BHP on consumers who remain on a marketplace plan. So digging into the updates, I'll try to go a little quick since I know we're here behind. First, a note of reminder that the CMS approved Oregon's temporary eligibility expansion of Medicaid at the end of April. And I think that's on the next slide, which will keep people covered by the Oregon Health Plan with income up to 200% of the poverty level until Oregon launches the BHP. Also, a reminder of the still, a reminder of the still relatively recent change in direction we got from CMS is that when Oregon implements the BHP, we must open it to all eligible individuals, not only folks coming out of Medicaid, which had been the plan for the partial year when we'll have it implemented. So this change in direction means that in the middle of 2024, people without coverage or who are already covered by a marketplace plan could enroll in the BHP if they're eligible. It won't happen automatically though. Folks would still have to, especially people with a marketplace plan, would have to take action to enroll in the BHP, either by updating their marketplace application or applying directly through the one system. Because some marketplace enrollees automatically re-enroll in their current plan from one year to the next without updating their application, full migration into the BHP from the marketplace is expected to take up to 3 years from 2024 until plan year 2027. We'll talk a little bit more about the impact of this more gradual migration from the marketplace to the BHP in a few minutes. But before getting into that, the next slide has a few more updates. First, I want to note that we are in the last week of our formal public comment period, which runs through this Friday, June 9th. We've held two official, oh, sorry, I spoke on that slide. One more slide, I forgot that we had an extra slide in there. We've held two official public hearings in May. There are also ongoing maybe we'll turn my video off if the sound is not good. Let's see if that helps to be speaking without being on camera, but hopefully that will help the connection. We also have ongoing engagement efforts with CCOs, with carriers, and others. We hold monthly meetings to work on operational details with CCOs. We've convened multiple meetings with carriers that have presented at other public meetings, including the Health Insurance Marketplace Advisory Committee. OHA is also conducting formal tribal engagement and have a formal tribal consultation on the BHP scheduled for July 6th. So especially given the timing of this tribal consultation, OHA staff is recommending that we bring the final blueprint to the policy board in August instead of July, as had been previously indicated. This will ensure we have ample time to reflect changes in the blueprint stemming from the tribal consultation, and really should not have any impact on our ability to have an approved blueprint ready in time to implement the BHP in July 2024. So before moving on to the marketplace focused content, I want to pause here in case anyone has a comment about this revised timeline or any questions about these updates. I don't know if anyone quick since we're a bit behind. Okay. Well, seeing none, and we'll have more time hopefully afterwards, I'll pivot to this first section discussing the marketplace impact of the creation of the BHP. First, a bit of background on the next slide about why we're looking into this and why there might be an impact on the marketplace. House Bill 4035 directed the task force to identify potential disruptions to the individual market and to develop strategies to ensure market stability and limit disruptions in coverage. As part of the task force work on the next slide, we engaged with our consultants and actuaries from the very beginning in April 2022 to consider what might cause potential disruptions to the market. Initially, there was concern about the risk pool itself and whether removing people from the marketplace into a new program would worsen the risk pool. But actuarial analysis based on data directly from the carriers actually found that the creation of a BHP would improve the overall risk pool in the individual market. I mean, a pretty small improvement, but still. However, the loss of something called silver loading will reduce silver premiums and the value of tax credits individuals receive, which results in increases to net premiums for some consumers, depending on their plan selections. So in order to talk about the impact of not having silver loading, I want to spend a few minutes to provide a background on silver loading, including what it is, and why we do it.
Hey, Tim, your audio keeps coming in and out. I don't know if it's like maybe you got to get closer to the mic on your computer, but it sort of kind of comes in at times and it sounds fine. And then at times it's just like very muffled.
I don't know that I can get any closer to the microphone. I could try to call in if that would be helpful.
That might be helpful, but I saw Laurel come off mute, so maybe Laurel has a suggestion.
Well, I was gonna say, Tim, if you first let me ask, how's my audio?
Sounds great.
My audio good? Okay.
Yeah.
Tim, I could take a pass at presenting these slides if you're able to send me your notes while I start presenting. I think that would be helpful to make sure that I'm not missing any of the comments that you were gonna make.
Sure.
Okay. Okay. So I'm gonna just take a pass at summarizing this slide one more time just to make sure that we're all tracking here. So our actuaries conducted an analysis of the impact that implementing a basic health program will have on the marketplace, on consumers who remain in the marketplace. What they found is that actually implementation of the basic health program will improve the risk pool for folks who remain in the marketplace. As Tim said, a modest improvement, but still notable. However, what they found is that implementing a basic health program will cause the state to reduce and ultimately lose something called silver loading. When that happens, silver premiums will reduce, which will cause tax credits to subsequently reduce and ultimately end up increasing net premiums for some consumers. On the next slide, we'll talk about what silver loading is and why we do it. So just some background on the Affordable Care Act here. The ACA created cost sharing reductions that are offered to folks, to a handful of consumers on the marketplace, specifically consumers who are less than 250% of the federal poverty level. Cost sharing reductions are funded by federal payments that are made directly to carriers. However, in 2017, the federal government stopped paying for these cost sharing reductions. But requirements for carriers to offer cost sharing reductions remained. In response, Oregon directed carriers to increase silver premiums. What that did is it made sure that carriers had the resources to continue to offer those cost sharing reductions. And because tax credits are based on the cost of silver plans, increasing silver premiums ended up increasing federal tax credits for all eligible consumers. I'm going to pause here because I've heard that Tim has called in. Tim, would you like to pick it up from here? Oh, you're still muted. Let's go to the next slide. I can keep going here while Tim continues to figure it out. So let's look at a few slides that attempt to illustrate what I just talked through here. So this slide represents what premiums looked like before silver loading. Again, tax credits are determined by the cost of silver premiums. So you see that dotted line at the bottom of the silver premium bar, that established the level of tax credits for all tax credit eligible consumers. On the next slide here, in 2017, the federal government stopped paying carriers for cost sharing reduction plans. So in response, Oregon directed carriers to increase silver premiums in order to offset the loss of federal CSR payments. When that happened, next slide, the tax credits for everyone increased. So what that meant is that bronze premiums became even more affordable and gold plans became more attainable. This is the current status quo that resulted from silver loading. Again, a response that Oregon made when the federal government stopped paying plans for cost sharing reduction plans. Next slide. When Oregon implements the basic health program, most individuals who are eligible for those CSR plans will transition to the basic health program. Because there will be fewer CSR eligible individuals, the costs that carriers will need to load into silver plans will decrease. And what that means is that tax credits will subsequently decrease for all eligible consumers. Consumers in silver plans it'll sort of be a wash for them, again, because tax credits are determined by the cost of those silver plans. But what will happen is there will be savings for the federal government at the expense of some gold and bronze consumers. I'll pause here both to see if Tim has audio and because I see a hand from Sandra.
So the 138 to 200 FPL, those individuals will still be eligible for the CSRs.
So those individuals will actually transition to the basic health program.
Okay.
And
so they will transition even if anything under 138 and below, because of the public health emergency expired. I guess I'm just trying to get this straight the way it's kind of changed. So if I'm a tribal member and I don't, and I are in that category, I have a choice for a bronze versus a silver, correct? Because there is no co-payment for that individual, is my understanding.
Yeah, so you're calling a good question here, which is the way that cost sharing reductions apply to tribal members. And there's a distinction here between the cost sharing reductions for tribal folks and the cost sharing reductions for folks under 250% of the federal poverty level. What we're talking about here actually has to do with the way that cost sharing reductions sort of impact the risk pool as a result of them going to folks who are 250% FPL and below. When we implement the basic health program, the majority of folks who are under 250% FPL, specifically folks 138 to 200% FPL, excuse me, will transition into the basic health program.
Automatic, correct? Is that auto enrolled? If they were in the silver versus the bronze or the gold, that's auto enrollment?
So those folks will, they won't be auto enrolled in the basic health program. Those folks will transition into the basic health program over the course of a few years. And actually the next slides are going to speak to that in greater detail. But the bigger picture here is when we implement the basic health program, the silver loading that we've been doing over the past few years will slowly decrease. And that will cause net premiums to rise across the board because tax credits will go down. It's a really complicated dance that's happening here. So
I'm trying to get that. And I understand what you're saying now. Okay, thank you.
Yeah, of course. Tim, how are we doing on audio?
Oh, let's find out. Does this work?
It does, much better, yes.
Do you want to switch now, Laurel, or do you want to keep going with this section? Either way, it's fine with me.
I'm happy to hand it back over to you.
Okay, cool. So hopefully this is a helpful overview of silver loading itself and kind of why there is this potential premium impacts for individual consumers. And I think then the next slide really gets into what the task force considered as ways to solve this problem. So the task force considered a couple ideas, each of which would have required a 1332 federal waiver, and the discussions with the task force and with CMS for these ideas started last spring. So first, the task force considered the idea of a premium assistance program using the federal savings that were just mentioned. This could have offset at least some of any premium increases felt by Oregon consumers. But because the state is still on the federal marketplace platform, implementing such a thing would be very complicated. We needed to administer it through the carriers directly because of limitations to the federal platform. And in the end, CMS determined that this simplistic structure of, say, a flat amount for every person, no matter their circumstance, would have run afoul of affordability guardrails associated with 1332 waivers. So then the task force pivoted and discussed the idea of what's called a gold benchmark, in which the lowest cost gold plan would become the benchmark for determining federal tax credits instead of a silver plan. This would insulate most consumers from any premium impacts associated with the elimination of silver loading, because we'd no longer be basing the tax credits on the silver plans, whose premiums are going to change. While initial actuarial analysis indicated this to be potentially feasible, albeit with a modest state cost, CMS then ultimately determined that they were unable to make this happen on the federal marketplace platform. And so it basically, us not having our own state marketplace technology meant the federal platform was not able to make the changes needed to implement these ideas. After rejecting these two proposals, the next slide shows CMS did come back with one final proposal for Oregon to consider. But like the other two ideas, it ended up not really being feasible on the timeline needed. So this next slide walks through this a little bit. Under this idea, Oregon would again use a 1332 waiver, but would establish a BHP lookalike program instead of using the regular basic health program process. This would have theoretically enabled the state to capture federal funds to run the program and to fund mitigation efforts. However, unlike with the basic health program, the funding mechanism in 1332 waivers does not increase to account for enrollment gains. This would put Oregon likely at significant financial risk if more people were covered by this new program than were covered under baseline marketplace assumptions that would be developed in conjunction with CMS. simply put, I think Oregon would have needed significant general funds to cover the cost of the program itself, and wouldn't have had enough federal resources to fund the additional premium assistance for people who remain on the marketplace. So the next slide offers a little bit of summary for what we just talked about. And before moving on to the actuarial analysis itself, just a quick recap. So Oregon now uses silver loading to offset the loss of federal CSR payments. But when people with income under 200% of the poverty level move into the BHP, this will go away. Silver premiums will go down, but tax credits will similarly decline. And while folks on silver plans won't really feel premium changes, people who currently choose bronze or gold plans will. And really, despite the federal savings this creates, Oregon's presence on the federal marketplace platform has thwarted our ability to capture these savings in order to mitigate the impact on consumers. So in the next section, we're going to present some of the actuarial analysis that quantifies what this consumer impact will be, and also discuss how the consumer mitigation or migration to the BHP over the course of a few years will help mitigate market disruption. So the next slide.
Can I ask you a quick, really quick question? So is the state looking at a platform instead of the marketplace? I know it's been undiscussed for over 2 years or so plus.
Yeah, I mean, I know enough to be dangerous on this. There is a bill, there is a proposal in the legislature this year, and from what I've understood, it has been a bipartisan proposal with a lot of support. But as Director Baden mentioned at the beginning of the meeting, the lack of quorum in the Senate has prevented this from continuing to move as well. So it is in the legislative process, and like everything else in the legislature right now, there's a lot of uncertainty about what will happen.
Thank you.
And there may be marketplace staff on here who want to speak more to that at the end if I said anything wrong, or maybe Dave wants to comment on that, but I think that's the general position.
And Tim, just a quick time check. We have about 10 minutes for the rest of the time, including discussion.
Okay, I will try to be quick. As I mentioned earlier, the BHP consumers who are BHP eligible consumers covered by the marketplace won't be automatically moved to the BHP. They'll have to take some kind of action. And even during open enrollment, consumers who don't update information from one year to the next can automatically remain in their prior year plan. The federal marketplace can't override this function, so we think some number of people from year to year will stay in their marketplace plan automatically. This will more slowly. This will mean that people will more slowly migrate into the BHP, and it will enable Oregon to more slowly reduce silver loading in 25 and 26, which will give consumers and the plans, the carriers, a chance to adjust. So maybe in the interest of time, I'm going to skip the next slide because it really offers the findings before we go through stuff, and I'll save some time. So maybe we can skip
Tim,
to 2
can I ask a quick question just on that slide that you just went through? You don't have to go back to it, but I just want to make crystal clear that people who are auto enrolled or who renew their marketplace plan will keep their tax credits that allow them to afford that plan, even though the BHP is eligible to them.
Yes, if they automatically re-enroll in their current plan from 2024 to 2025 and don't update their information and don't move to the BHP, they will still have access to their marketplace tax credits until they go update their application and are moved to the BHP.
Okay, so if they update their application or try to move to a different marketplace plan, their only choice then will be BHP or pay the full premium on the marketplace.
That's right. Then they would be referred, then the federal marketplace would refer them to the state to process the BHP eligibility and enrollment in the same manner that it would happen now if somebody was eligible for Medicaid. Does that help?
Yes, that is really helpful. And I think this nuance is actually going to happen to quite a few people. And so I know that we are looking to help consumers through that transition process. So thank you.
Yeah. And happy to talk more about that. I think there's another spot later where that comes up. So the next slide really gets into showing how this marketplace, how the BHP enrollment. Oh, I'm sorry. We do have and I'll skip this too. We have assumptions because the actuarial team that put together this analysis really wanted us to make sure that we're clear about the assumptions used, but we don't have to spend the time to chat about this right now. So this slide really shows how the size of the individual market declines as people move into the BHP. The largest jump we expect will be in 2025, with smaller migration in 2026 and 27, and new entrants to the individual market will keep happening in 26 and 7 and stem some of the decline in the overall size of the individual market. And then the next slide shows how the silver load also steps down over these 3 years as people move into the BHP. In year 1, it drops by about half, still ranging from about 7 to 8%, compared to right now, it's about 14 to 15% across carriers. Carriers will have specific numbers. And there's still a small silver load remaining in 2027 because folks with income between 200 and 250% of the poverty level can qualify for some cost sharing reductions. As we said earlier, the falling silver load is expected to lead to movement within metal tiers, which is on the next slide. I think we can skip that quickly so we can dive into the information, but folks can come back and look and see that people are expected to shift between gold and bronze and silver plans. So the next slide, I think, is the first one that really shows what is the impact. The first bar shows the net premium changes for subsidized consumers across all income levels, and then we see in 2025, 2026, and 2027. Following this, there'll be specific slides for income cohorts. But across the whole individual market of subsidized consumers, nearly 60% would experience premium increases of less than $25 a month, even by 2027. And again, this will phase in over time. But some number of consumers, as evidenced by the green bars at the top of the 2027 column, will experience premium increases of $100 a month or more. It's worth noting that all of these, the experience of an individual consumer will depend on their plan choice. And then going into the next couple slides, since I know we're short on time, we can see how this differs by income cohort. I think it's a good thing that the premium impact is smaller for folks at lower income levels. So for the lowest income cohort that will remain on the marketplace after the creation of the BHP, 80+% of folks would experience a premium increase of no more than $25 a month. And looking broadly across this group, the average increase is actually less than $5 a month. So moving up the income ladder, the expected premium impact shift. And so the next slide shows the 300 to 400% cohort, and you can see there's a little bit more gray, a little bit more green, and a little bit less blue. So the premium increases are slightly higher for this cohort than for the lower income group. Still, nearly 30% of folks in this cohort don't experience premium increases at all, or experience premium increases of $25 or less. And the overall increase, there does start to be a few folks in the $100 or more range. And the average increase for this cohort is about $46 a month. Again, in 2027, and those are numbers that in large part are getting phased in. And then finally, we can see the cohort over 4 times the poverty level and receive a larger premium impact. So the next slide. Still about 40% of consumers experience increases of $25 or less, but also some consumers are in the higher category. And across this income range, the average is about $64 a month of premium increase. For all of these income cohorts, it's important to remember that whether a person, an individual experiences premium increase will depend on plan decisions. Folks in silver plans now won't feel the increases because of how the subsidies work. And people who decide to shift, say, from gold to silver might experience a smaller increase or avoid increases altogether, whereas somebody who decides to remain in a gold plan might experience that's maybe why they're experiencing the larger premium increase. So with just a couple more slides, the next slide helps put all of this into context, and I think that that's important to do, especially with the benefits of the basic health program for the estimated 55,000 people who would get to stay in their CCO, to stay on the Oregon Health Plan, and for other consumers who will have a more affordable coverage option through the BHP than they may now have on the marketplace. Without a BHP, more than 20,000 people would likely end up uninsured if they were to lose OHP coverage during the redetermination process, which is not a reflection on the amazing work being done to connect folks leaving OHP to marketplace coverage, but is our expectation based on historic uninsured rates for people in the 138 to 200% FPL income cohort. And contrasting that with the 1,800 people that the actuarial analysis expects to drop marketplace coverage over 3 years, we could see that the creation of the BHP is still the best way to protect the coverage gains that Oregon has achieved over the last 3 years. Finally, just wrapping up with a few takeaways on the next slide. Some of these were in a previous slide that we skipped as well. As we've discussed, migration from the marketplace to the BHP will happen over 3 years, which slows down the premium increases and potentially gives state policymakers time to respond if the impact differs from projections. Marketplace consumers, especially those who choose bronze or gold plans, may experience premium increases, though the bulk of that impact is felt by folks with income over 400% of the poverty level, and the impact for folks in the 200 to 300% FPL range is much smaller. People will also make different plan selections, likely moving modestly away from gold into silver and bronze plans. And finally, as we just said, the creation of the BHP best protects the overall coverage gains that Oregon has received by ensuring that more people who are covered by OHP now are able to remain in their same plan and not risk losing coverage as they transition to another source of coverage. The last slide and I can end on this next slide is just a couple comments about what's next. We're incorporating our public comment into we'll be incorporating it into the blueprint so that we're ready to submit it in August. We'll be working to incorporate changes based on the tribal consultation as well. We're going to be continuing to work with DCBS to estimate mid-2024 migration from the marketplace and how they'll communicate any assumptions about that to carriers. And as Tristan mentioned, we'll be working to develop a communications and outreach plan for 2024 to really help minimize confusion and disruption for consumers and ensure that people kind of know what to do if they want to stay in their same plan and not have to switch in the middle of the year, or if it's really important to them to seek the basic health program. With that, I'm done, and I'm really sorry about the technical challenges. And thanks, Laurel, for stepping in there in the middle. Happy to answer questions if y'all have them.
All right, thank you, Tim, and thank you, Laurel, for stepping in during the audio challenges and moving forward with the presentation. Very impressive. Yeah, silver loading and tax credits, all very complicated stuff, but it sounds like you guys have a strong handle on it. Any questions, additional questions or comments from the board? John.
Well, I just say, wow, tricky stuff. In terms of transparency, isn't this a lot better than the scenario where, well, federal government has stopped paying for these folks, so they're back out in the market. You know, they're uncovered. So I'm impressed. I'm not sure I understand all this, but you know, impressed with Oregon's effort to maintain that status quo. And I think clearly Oregon is stepping up to take on more risk and trying to protect the marketplace and the marketplace carriers from more risk, which is, you know, unfortunately, a reasonable thing to do here if you want to keep the carriers in and the marketplace in, and some people do prefer that coverage. So thanks for keeping at this.
Thank you.
Great. Let's hope your assumptions are accurate and things work out just like you were planning. So any other comments or questions? All right, well, thank you. Yeah, I agree, very complex work. It was hard to really follow, but you know, we trust the experts. Yeah, thank you so much for all your great work. Let's close it out today with an update from Sarah Bartleman. Sarah, there was a public hearing a few weeks ago. Tell us about it and tell us what your next steps are.
Yeah, thanks, Oscar. Thanks, Kirsten. I just wanted to give you a really quick summary and invite board feedback, which you can provide today or send me a message offline. That would be great as well. So for our cost growth target program, you probably saw we published 2 reports earlier in May, looking at healthcare cost growth between 2018, 19, and 20, and then 2020 and 2021. On May 17th, we had the first part of our public hearing. We had a lot of board support for that public hearing, so thank you for that. Oscar, Kirsten, and Bill all played really key roles in helping pull that hearing together and identify speakers and moderate panels, and just really appreciate the board's show of support and commitment to this work. At the May 17th public hearing, we shared background about the cost growth target program, where it came from, why we're doing this work. We had several really powerful consumer stories about the impact that healthcare costs are having on them and their life. We shared the 2020 and 2021 data, and then we closed out with a payer and provider panel discussion. The recording is posted online, and this is also potentially an opportunity if any board members who participated or were listening into the hearing have any reflections. We'll pause there for that in a second, but want to just let you know what's coming next. So we agreed with our advisory committee to do our cost growth target program public hearing in 2 parts this year. So May was part 1. We are having part 2 in September. And the intention is that the September hearing will be focused more on hearing from payers and provider organizations, potentially with a focus on actions. What have payers and providers already done to try to meet the cost growth target? What do they plan to do moving forward to try to meet the cost growth target? So we are beginning to work to put together that agenda for September. We're beginning to think about who we might want to invite as panelists. Unlike other states, we're not necessarily going to subpoena people to come to the public hearing, but we're looking for more of a collaborative invite to participate, come talk about your experience, talk about cost growth, talk about strategies. So we're starting to think about who we might want to hear from, and we would love to ask the board if you have any input or suggestions for us in helping shape that September agenda and identifying panelists. So some of the questions that we'll be talking about with our advisory committee in our meeting next month are, who do you want to hear from? Do you want to hear from the organizations who exceeded the target in 2021, those who met it, a mix of both? Are there any outliers, different parts of the state, different parts of the markets that you want to hear from? So I would extend all of those same conversations to the board and just let you know that we're planning over the next couple of weeks and would really welcome your feedback for September. And of course, you are invited to participate in September's hearing. We'll reach out with more details about that. And I will stop and see if Bill, Oscar, or Kirsten have any reflections from May that they want to add in.
Thanks, Sarah, for the quick update. I thought that meeting was very effective and really well done. It presented the information very well. And I thought particularly the consumer stories were very compelling. And I hope we can keep the patients and consumers' voice in front of that group, as well as the Oregon Health Policy Board, as the Ombuds report did earlier during our meeting today. I think that's so important. It often gets lost when we get deeper into discussions about complex policy issues or industry financial issues. Those are important too, but we sometimes there's danger of losing sight of the patient's voice. So I appreciate the work you've done and others at Oregon Health Authority to keep that perspective in front of us, since that's the ultimate goal, improving quality and equity and affordability for everyone.
I too echo Bill's comments. I will just add, I think it's interesting to see this program develop, right? This was our second hearing, and each of these reports are evolving, right? For the first time, we're seeing provider specific measurements, and as we go forward, we'll move into potentially improvement plans, and maybe the tone will shift where it's needed, and I also think there's great value in the collaborative tone that has been established. I think one thing that is kind of nagging me about this program is that I think we will need to eventually have a bit of an independent voice of like, this is a driver of cost that needs to be addressed, and how are we addressing it? I think there's incredible space, and should be space, for the industry to bring forward like examples of how they're addressing costs, and provide best practices, and to identify their own challenges. I think we also need the opportunity to have another voice, OHA's voice. I think it needs to be of like, oh, we got to address this elephant in the room. And so I just want to flag that, as I think as this program evolves, that this independent voice independent of the industry evolves along with it, is what I mean, because it can be hard. I think having these consumer voices is important to a grounding, but it's a different voice, and having these consumer voices is powerful. And as someone who works with those consumers to bring them, it can be hard, because these are they're sharing immediate pain. And we're talking about a program that is a long-term change, and especially given like this year's dynamics, which were all understandable and stuff, it is hard still from a consumer perspective to be like, yeah, these double-digit increases, they happened. And so I just, as we go forward and this program evolves, I'm looking for a strong, independent voice in between consumers and industry.
Kirsten, thank you for saying that. I think we just came back from a meeting with the other cost growth target program states last week, and a couple of things that I want to share back from that. This sort of independent voice, and who is the objective identifier of the cost growth drivers is something that other states are also wrestling with, and we all are implementing the program a little bit differently, where some states, they've contracted out or they have a university partner who does their cost driver analysis and are able to really bring in that third party independent voice. And I think there's some real value there. We have chosen to build a lot of in-house infrastructure, and so that does put some of the onus on OHA to be in that role. And I think, fair point. Thank you for saying that. One other thing that came up in our meeting with other states, we were talking about cost growth and commercial cost growth, in particular in 2021 across all of the states. And there was a huge variation. There's an article that Health Fairs is going to put out later this month that talks about the comparison between the states. And I want to say it ranged from 9% commercial cost growth in Rhode Island. They just managed to avoid double-digit increases, all the way up to 18% in Connecticut. And those states are right next door to each other. Oregon was 12%, so we were on the lower end of that. But there was a huge variation in those experiences, and I think we have a lot to learn from the other states and continue that bigger picture. Oscar, any other board members have comments or feedback for us?
No, I just want to say good work, and thank you for letting me be a part of it, be a small part of it. So really appreciated all your organizational skills for getting this hearing happening, and then looking forward to the September hearing. Any other comments from the board? All right, keep up the great work, Sarah. Thank you so much for everything you're doing.
Thank you.
Okay, so wrapping up, we know that we're going to hear from Tara, and she's going to let us know eventually when this MODIS webinar is going to happen, where we'll hear more about the director recruitment. So keep an eye out for that. Just an important reminder that in July, we're not meeting the first Tuesday of the month. We're actually meeting the second Tuesday of the month because of the holiday. So just making sure that folks know that our OHPB meeting in July is happening on the 11th. And then finally, there's a webinar scheduled on Tuesday, June 20th from 8 to 9 a.m., which will focus on open enrollment and how to support Oregonians that are not eligible following the end of the pandemic redetermination process. So all the details about that webinar are located on the OHPB website. So take a look there for all the Zoom information and other logistical information. All right. Thank you so much for all your time and attention today. And I look forward to seeing you in July.